Everybody, this is being live streamed. I'm Dr. Meenakshi Deshpande, also the organizing chairperson for EVECON. So I welcome you all for this first ever event of EVECON conference, which we are starting today. As you all must have understood by now that we have got many papers and presentations of posters. I think they are equal to 50, isn't it? Yes. So we have divided them into two parts. We are having them correct. We are having them half today and half tomorrow, because considering the time to be given to each participant, it would have been difficult if we had taken everything on Friday itself. So last week we decided to divide them into two parts, like posters tomorrow, that is on 26th of August, and free papers today, that is on 25th of August. So we have got 4 judges also. And I welcome the judges today, Dr. Lakshmikant Yenge and Dr. Varsha Shinde. I'm not seeing her here. Dr. Varsha, have you joined?
Yes, she has joined. Yes.
Yeah, sure. Here. Yeah, good afternoon, Dr. Varsha. And good afternoon, Dr. Lakshmikant Yenge. You will be officially introduced also now. And I welcome you to this August audience today of the 24 free papers which we are having today. I would also like Dr. Ananta Kulkarni to come over here and help out with the comparing if you want, because he is here in the auditorium, in the boardroom. And we are doing this with the help of DigiShield. We are doing this online so that many people have joined from all over Maharashtra. And that was the aim of this conference free papers, because we wanted students from all over Maharashtra to come up and join. Because if we would have made it only physical, only the physical nearby people would have joined, and that would have been difficult for us. So thanks for everybody for joining today. And I would now give the proceedings to Dr. Geetanjali and Dr. Ananta.
Yeah. Okay, so let's start. As Dr. Meenakshi has said, we have many students who have joined from all over Maharashtra, and we are starting today's competition. So the first presenter is Dr. Prasanna Gadre.
Yeah, hello. So I would start sharing my presentation.
Yes.
Yeah, from BJ Medical College and Sassoon myself, and going to highlight and demystify the enigma of female sexuality in today's modern world. So basically reporting of women directly to my sexuality clinic, and the last 3 decades, because of the arrival of technology, that has influenced the reporting of women for the sexual problems in clinic, which is a good sign. But the bad sign is, I would say, that they are bold as regards sex, but not as regards sex education. Yeah, just a second. The slide stopped. Moving ahead. Hello, am I audible?
Yes, you are audible.
Yeah, I don't know why the slide is not moving.
Yeah, before I say, can you see the judges? Who is going to look after the timing part?
Yes, I'm looking.
You are looking.
Yeah.
Okay. So
yeah, now it's there. So
yeah.
So I want to offer the panoramic conceptual statistical view, okay, of female sexuality matter scenarios and situation, not just the conventional female sexual disorders. The method is that there was an analysis of the documents records in my own clinic as well as in the journals, okay, and the biopsychosocial model was being applied to see the patterns of the women's sexuality, and the 11 subjects of humanities definitely helps medicine. So this is the statistics. Well, 8% were the women affected when their male was having a sexual disorder. 12% was a conventional classical female sexual disorder. 15% was related to the solid genital organs and its skin, the vulva, vagina. And the most important thing which I am going to now share is this 65% model. So what are the observations, interpretations, and discussions that I would definitely let you know? Direct reporting proactively by women, and she takes even the initiative when she comes along with her man for the couple problems. Mother and mother-in-laws are inhibitors in the happy marital sexual life. Disturbed marital relationship when the husband is mama's boy and effeminate personality. Non-consummation of marriage in last 10 years is very common, along with 40 to 60% idiopathic cases of infertility where husbands were either homosexual perverts or with less sexual drive, or maybe the woman was career oriented, not living with husband and not with maternal instinct. Swapping of partners has become also very common. Widow, divorcee and spinsters have increased reporting for their sex counseling. The three clusters of psychiatric personality type A, B, C definitely affects the sexuality of the women. Condoms in the children's school bag and the pubertal adolescent juveniles, which are active after the age of 12, 13, 14, along with the sexually transmitted diseases. Point to be noted is that the viral infections have become more common than the bacterial, and masturbation has increased. And the point is that the vibrators and dildos can act as a secondary fomitic transmission mode when multiple partners are there with lack of hygiene. One elite female was being abused by the members in her family and relatives, and she had a disturbed relationship with her husband. Postmenopausal cases were common, and I have treated one case where women enjoyed 16 partners. That was really unbelievable. LGBTQ is on rise, where I interacted with a lesbian couple. One was a bachelor trans man and another was a divorcee bisexual. So what are the conclusions? A know-how of different female sexual disorders is very much important to identify them. Body, mind, sexuality and society cannot be separated. Hence, family physician becomes a versatile chameleon, for that matter, any doctor, when he understands all this, and a better therapist. Ultimately, as Love and Bailey says, your eyes can see what your mind knows. And sex therapies and psychotherapies should work around this biopsycho socio-sexual model. So see, what is the conclusion? That liberation and emancipation, okay, is a package. We cannot leave sexuality. Women have become sexually liberated and emancipated, but women are in conflict. Okay, on one side, they want to seduce the men and attract them, but on another side, they are unable to express and experience healthy sexuality. And another was, or they were expressing, but there was no proper sex information and knowledge. So these are the social, religion, culture, gender, socio-economical strata, changing power structures, Jungian collective conscious, okay, and the eros and pathology of sexuality was influenced by sex education, sexual romantic experiences. Women gets a chance to go to a doctor for so many things, and hence a doctor should take opportunity to extract and inculcate healthy sexual knowledge and come out of the typical female sexual disorder and sexist model and have this bio-psycho-socio-sexual approach. Well, these are the references. That's it. The time is 5:58. Thank you.
Thank you, Dr. Prasanna. I would like to know judges to ask him questions now. He has a second paper as well. So let him present the second paper and then we can take question answers for 4 minutes.
If you have time, I would just like to have what was the methodology? Sorry, I missed that, so I'm consuming a lot of your time.
No, that's okay. That's
how
okay.
was it conducted?
Yeah, for last 28 years, whatever practice I am in, I've given 1800 hours of counseling and almost more than 1000 sexuality patients I have treated. So whatever those came, I happen to do a classification: male disorder, female disorder, concentrated on female sexual disorders, and in my own clinic. And at the same time, these are the references, and I did a meta-analysis of which I have given. So whatever the cases had come to my own clinic, I have used that data only to put forward. The clinical cases were classified and this picture was given.
So these are all from the registry of the patients who attended your clinic?
Yes, yes, madam. They are very much authentic and I have all the full data along with me in my files.
So you are basically a dermatologist?
Yes, I'm basically a dermatologist and a cosmetologist, and from STD I went to sexual medicine, And from dermatology, I also went to the aesthetic medicine and cosmetology.
The presentation is very good.
Thank
And
you.
the concept also of this e-poster presentation is something which is quite new.
Yeah.
So appreciate that.
Thank you, madam. Thank you so much.
Thank you, Dr. Prasanna. You can go ahead with your second presentation.
Okay. Okay. Just a second. I will stop and
Yes.
Yeah, new share. Okay. So that is why women want to look beautiful. And here I go. 1 minute. So beauty and aesthetics, they go hand in hand. Yeah, here I am. So this is the title, where the planning was a patient-centered therapeutic approach for aesthetic skin problems, where why women want to look beautiful is what I observed. So inner and outer beauty both are important, but in today's era of image impression and presentability and open sexuality, outer beauty has taken precedence. So what are the reasons why women want to look beautiful? So the method is that 30 patients, this is just for the, because this paper I did 3 to 4 months ago, many cases have been coming, but I selected 30 patients with common facial skin disorders, with acne, with scar, rosacea, tanning, hair loss, melasma, hirsutism were selected. They were subjected to the survey question made up of 30 questions. 3 were open-ended, 27 were leading questions. Interview and counseling lasting from 30 minutes to 60 minutes, and this is genuine. Where per patient was given. Okay, again, there is some problem. 1 minute. Yeah. The screen is not moving ahead. 1 minute. Yeah, all answers given semi-quantitative subjective rating, where 0 is I am not bothered as regards particular attribute, and 10 is I am totally disturbed. 1 copy was given, and Carl Rogers client center approach for analysis, assessment, prognosis, and patient satisfaction was taken. So this is that questionnaire. Okay, 30 questions were asked. So 5 groups of questions and even 5 groups of eves or reasons or female were there, and 30%, this is a law of 30, I would say, a clustering of the patient as to why they wanted to become beautiful. So 30% women said that they were losing their treasure of cosmetic aesthetics and youthfulness. 1 were in the situational demand, where they wanted to go for premarital shoot or their own or some another's marriage, socializing, or some festival ceremonies, celebrations. Then artists, actresses, air hostess, and women who were going for marketing, sales, and having presentations in front of customers or vendors or board of directors. They wanted to become beautiful. This is the 5M factor, I would say, the group 5. So some women came because they were not looking into the mirror at all, and some women were pushed by their mothers because they were continuously looking in the mirror because of their facial problems, or they came to the clinic because of some criticism and remark on their blemishes and marks, or again mother-in-law nagging, where comparison of her complexion either with sister-in-law or somebody was done, and manipulation. And obviously the last group was that the partners, for their partners, they wanted to be hot in the bed, or their partner had passed some dirty comment on them. Now this result is that all the patients were affected 100%. Okay, psychologically it was bothering them. The facial skin problem, because of that they were feeling awkward, embarrassing, ugly, disfigured. They lost their self-esteem, confidence. They became submissive with a low inferiority complex. But a point to be noted is that 20% of the people who fundamentally had a good self-esteem, they had these scores around 5 out of 10, while the women who were having basically poor self-esteem were having these scores 8 to 10. So the discussion is that aim was scientific curiosity. Of course, apart from medical approach, weightage was given to the need, emotional and intentional orientation of the female patient. A female should know what I'm doing. That means taking the treatment as for what purpose. Then the Questions help the doctor, patient, as well as for the doctor relationship. Does it influence the therapy? Very much positively. The medical philosophy, which I also happen to tell my students, is don't just treat the itch or the rash, okay, but treat the body, okay, and even treat the mental itch behind the itch or the body segment, the skin as a whole, and the human in women. Help patient to convert the attitude of beauty, okay, where from desperation she should go to the passion. Beauty should not be desperation but a passion. That is what we want to tell people. So again, in the therapeutic approach, inner and outer beauty were given importance. They were told that all these procedures are lifelong, like weight maintenance, aesthetic, anti-aging. Counseling approaches from image management to handling criticism. How to tell them that they should not be bothered as regards log kya kahenge and the peer pressure. Self-esteem counseling technique by Nathaniel Brandel, and how to move them from helplessness to learned optimism. Rational, emotive, and cognitive therapy and sex therapy, accordingly, as per the intentions they were offered. So that gives opportunity for patient to know why she is doing what she is doing apart from regular skin aesthetic treatment. The results are faster. Her compliance improved very much rapidly within 6 weeks to 6 months. Okay, usual it takes time, but here average 15 days to 45 days were taken, and the scores dropped substantially, and she herself got a clarity of purpose. So skin and aesthetic disorders have cosmetic, psychological, social, professional, sexual signification. Then it becomes her existential, emotional, and experiential crisis. It is essence for a woman that definitely hits her entire holistic functioning, along with moral well-being, confidence, performance, and self-esteem. Direct confrontation with patient's intentionality to take treatment has achieves better therapeutic alliance relationship and to get a focused, meaningful, better, faster results, and helps her to know what she should expect from herself, from the doctor, disease, and the treatment. And finally, I would say that we should tell her that the clarity in life is important, because then she has a goal-oriented approach for her problem. Yeah, that's it. I will again, I've finished my presentation.
Yes,
Dr.
thank you,
Kadri.
Dr. Yeah, judges can ask the questions, and by then you can stop sharing
Dr.
your
Kadri.
screen.
Yes.
Dr. Kadri.
Yes.
Good afternoon. I am Dr. Aniket Joshi. I am a physician.
Yeah.
I would
Hello,
like
sir.
to have your method was quite good. It was
Thank you, sir.
First was a retrospective registry, and
Yeah.
in this you have a questionnaire.
Yes.
I would like to have to see more of statistics, like in what proportion patients would have got that score, or we have done a scoring system.
Yes.
So in that score, how many patients had, what percentage of patients had what score? If you
Yeah.
have
Yeah.
got that slide.
So yeah. So should I reshare it? So basically what I found was that 100 as psychological disturbance was 100% in all the patients. Okay. And
Have you-
except,
Yeah.
except one, I would say, among the 30, because she said that she was not interested, her mother only asked to come. So only one patient was not bothered. She was apathetic in that way. While as I showed in my slide, that almost 30% of clustering was there for the groups which I have shown. Situational demand was there, so 30%. So situation might vary. One person would say that it's my own marriage. Another person would say I want to look beautiful for some ceremony. But 30% clustering, it happens, and that's why I said rule of 30%. So rule of 30.
Sir, that is right. But if you have got more elaborate statistics, it would have
Yes.
been much better, because your
Yes.
study is quite good. But
Yeah.
I would like to have more statistical presentation if you have any.
Sure. So I accept what you say, sir. Actually, I have been practicing for 28 years, but this sudden idea came in my mind 3 to 6 months ago. I formulated it, made it more authentic, and really I have taken only 30 patients. I want to go for 100 patients, and at that time I will definitely do that statistics, individual response of individual question. Today I have not done, but I accept what you say.
Okay. Thank you.
Yeah.
Thank you.
Thank you, sir.
Okay, thank you, Dr. Gadre. Can we move to the next presenter, please? Dr.
Thank you so
Shraddha
much.
Yadav. Yeah,
Yes,
thank you,
ma'am.
Dr. Gadre.
Yeah.
Yeah, Dr. Shraddha Yadav,
Yes, ma'am.
please start sharing your screen.
Yes, ma'am.
We have 3 judges. Dr. Aniket Joshi is a consultant physician. Yes, Dr. Shraddha,
Yes, ma'am.
go to slideshow and start your presentation.
Ma'am, can you see my
Yes, we can see your slides. Please
Okay.
go ahead.
Ma'am, my topic is histomorphological lesions in Hansen's disease and its clinical correlation and the social aspects related to it. Ma'am, the introduction. The fear of leprosy leads to the stigma and discrimination, and is due to the lack of understanding and knowledge about leprosy, which thereby causes misconceptions about the disease transmission and treatment. The structure of the Indian society, with its hierarchies and power structure, is an ideal place to understand the experience of oppression. Focusing on the cultural and material dimensions will give a true comprehension on the social relations and inequalities in the studied areas. I can't share my. A little bit about leprosy. It's a chronic infectious disease which is caused by Mycobacterium leprae, which is an acid-fast rod-shaped bacilli. It has been known to mankind since ancient times. It affects the peripheral nerves, skins, mucosa of the respiratory tract, and eyes. There were approximately 1 lakh cases of leprosy detected in 2020. It is endemic in several states and union territories of India. There are 2 classifications that are used. That is the Ridley-Joplin classification in which comes from 1960. That is tuberculoid, borderline tuberculoid BT, borderline BB, borderline lepromatous BL, and lepromatous leprosy. In 1982, WHO classified it as multibacillary and paucibacillary. The aim of the study is to find the prevalence and histomorphological spectrum of different types of leprosy and correlate clinically, and how far does the stigmatization with those affected with leprosy bring in differences in the social status between men and women. Ma'am, material and method. The skin biopsies that we received was fixed in 10% formalin, routinely processed with paraffin embedded sections, and then stained by H&E and phytophoreco stain. The signs and symptoms of leprosy. Symptoms may affect mainly the skin, nerves, and mucous membrane. It can cause a hypopigmented patch on the chest, which is a classically...
Excuse me, if I can interrupt, can you just give us what was the aim of the study?
Sir, the aim of the study was to study the histomorphological lesions in different types of leprosy to correlate...
You can go ahead. Go ahead.
Yes. Thick, stiff, or dry skin, painless ulcers, swelling, lumps, loss of eyebrows. Since Hansen disease affects the nerves, loss of feeling or sensation can also occur. If it is left untreated, the signs of advanced leprosy can include paralysis and crippling of hands and feet, shortening of toes, non-healing ulcers, blindness, loss of eyebrows, nose disfigurement. These are the clinical pictures. The first picture shows multiple small papules and nodules with few discharge. That is classically seen in the severe form of leprosy, that is the lepromatous leprosy. The second picture shows nodules in hand, which is accompanied by weakness. The third picture is showing skin thickening with nodules on the auricle of the ear. This the picture above below that shows infiltrated nodular lesions, that is the papules and nodules of various sizes can be seen. And the last picture shows multiple bilateral flesh-colored nodules over the back, which is classically seen in the severe form of leprosy, that is lepromatous leprosy. In the study, 391 cases were included. Indeterminate was the most commonest form of leprosy, seen in 93% cases. Borderline was the second common. Tuberculoid leprosy in 66, lepromatous in 56 cases. 50 cases were of borderline leprosy, 18 cases were of histioid leprosy. 6 cases showed type 1 lepra reaction and 5 showed type 1. Maximum cases were in the age range of 31 to 40 years, which was followed by 21 to 30 years. Majority of the patient in our study was male. This is a slide picture which is showing numerous acid-fast bacilli in pink. of the fight for acoustin. Discussion. The attitude of society, methods of detection, type of person carrying out the survey, frequency of examination, the criteria adopted for diagnosis, the type of classification, they all affect the description of the disease. Leprosy is usually said to be more common in males than females, but this can also be due to the fact that the industrialization, urbanization, and more opportunity for contacts are basically seen in male. Another fact is that the social customs and taboos, which account for smaller number of females who are reporting for treatment to the hospital with the same. A case study which was done by Chaturvedi, it showed that the females were more affected than males, as contrary to the belief that the males are more affected. There are several factors which includes the sex predominance in the endemic areas. The main factor causing the sex difference is that the opportunity for contact and is practically noted when the opportunity for contact is the same. It was noted that the opportunity for the type of leprosy in males and females for the histologic type was almost the same. The situation of women in India needs special attention in terms of leprosy, because discrimination against leprosy affected people has certain distinctive features. First is the misunderstanding of the nature of the disease. The psychological emotional responses towards it and are often described as stigma, which results in discrimination. These expressions are not due to ignorance or laziness, but it is outwardly indifferent stance with regard to hardships caused by class, caste, and patriarchal power structures. It is an endurance strategy utilized by them to manage oppression. The conclusion: stigma of leprosy remains an ingrained element of society, with family and community-based stigma excluding individuals from activities and interactions. There are clear gender divisions in these restrictions, which conform to traditional gender roles, while both men and women are negatively affected in terms of family and marital lives. It has been observed that women suffer more isolation and rejection. Ma'am, that's my time.
Okay, you can stop sharing your screen and judges can ask you questions.
Yes.
How many were males and how many were females in your study?
Ma'am, out of the 391 cases, approximately 235 were males and 150 were females. This was a study done, like I collected the cases over the period of 2 years.
So more were males.
Yes, ma'am. Ma'am, that is what we try to understand, show that the discrimination is more, and females usually they don't come and report because of the stigma that is associated with leprosy.
But this, there are two things from my side. The first one is the aim of the study was to look for histomorphological features, and the conclusion was the gender difference or separation. These are not going hand in hand. So whatever is the aim should possibly be the part of conclusion, which is not the case here. The second thing is, just because the difference is there, males are more reported or males are more diagnosed, doesn't mean that there is oppression on the part of the females to report it or recognize it. What we needed was to go in the background and see how what was the time from the onset of symptom to the first diagnosis or first presentation to the clinician. If that was the significantly different in males versus females, possibly that would have made a stronger case for oppression rather than just a difference in the overall incidence or prevalence.
Sir, actually,
having said that, I think 400 odd cases of leprosy over 2 years is a significant burden yet. That is learning lesson for most of us who are sitting, who possibly have not seen even a single case of leprosy in last 2 years.
Yes.
I would like
something
to
which is still.
Yes.
I would like to there are many cases of leprosy. I myself have worked for Bandorawala Leprosy Hospital, and most of the cases in the past have received Dapsone, and now they require multi-drug treatment because they are getting the reoccurrence of leprosy in them. So this is the case. My simple question to you was, from where did you take the biopsy?
Ma'am, the biopsy was, we received the biopsy from the lesion, like the skin lesion, whatever biopsy we received, we basically processed that.
Otherwise, from where do you take the biopsy to diagnose leprosy?
Ma'am, biopsy, we take different types of biopsy. We take skin smear biopsy, then we take from the earlobe. Then we take
Okay.
if the nerve is involved, then we take the nerve lesional biopsy. So different types of biopsies according to the presentation of the clinical presentation of the patient, the papules, macules, the edge of the
Yes.
ulcer.
That is
Okay.
what she was more interested in, edge of the lesion.
Yes.
Yes.
Thank you, Dr. Shraddha. You can stop sharing your screen. And our next presenter is Dr. Chaitanya Gadvi. She had problems in sharing. Dr. Shraddha, please. Yeah.
Yes.
Chaitanya,
Yes, ma'am.
have you got it? Yeah. Have you got your PPT? Please open on your laptop, minimize it, then click on the Zoom window. Yes, perfect. And start presenting.
My topic is serum lactate dehydrogenase, a biochemical marker for the prediction of the adverse outcome in preeclampsia. Introduction. Hypertensive disorder of pregnancy are one of the most common complications in the pregnancy and contribute greatly to maternal and perinatal morbidity and mortality rates. Hypertension of an underlying pathology which may be pre-existing or appears for the first time during pregnancy. These conditions, however, are largely preventable, and once detected, they are treatable. Hypertension during pregnancy is diagnosed when the systolic blood PP is 140 mmHg or more, or diastolic pressure is of 90 mm of Hg or more, measured on 2 occasions at least 4 hours apart within 7 days. Preeclampsia is multi disorder that complicates 5 to 15% of pregnancies in India. Preeclampsia is pregnancy-induced disorders characterized by hypertension and proteinuria. Preeclampsia is multi-system disorder and lead to a lot of cellular death. Lactate dehydrogenase is intracellular enzyme which converts pyruvate to lactic acid during the process of glycolysis. Glycolysis is a major energy pathway in the placenta. Hypoxia in preeclampsia further enhances glycolysis and increase LDH activity. Studies have shown that LDH activity and gene expression are higher in placenta preeclampsia than normal pregnancy. Hypoxia induces LDH isoenzyme activity in trophoblast, resulting in higher lactate production. Elevated level of LDH are indicative the cellular damage and dysfunction. So it can be used as a biochemical marker because it reflects the severity of the disease and occurrence of the complications and fetal outcome. Its estimation would prove useful because these complications are preventable. Aim of the study is to find out the role of serum lactate dehydrogenase level in prediction of the adverse outcome of the preeclampsia. Objectives are to estimate the level of serum LDH in preeclampsia, to study the correlation of LDH level and severity of the disease, to study the correlation of LDH level and occurrence of complications, to identify the better severity indicator in maternal and perinatal outcome. Subjects were records of women with preeclampsia. Inclusion criteria: records of women with preeclampsia having singleton pregnancy, age 18 to 30 years, preeclamptic woman whose blood pressure was normal during first 20 weeks of gestation, no previous history of hypertension. All cases were in third trimester of pregnancy. Exclusion criteria: records of women with history of chronic hypertension, diabetes mellitus, drug intake, smoking, alcoholism, liver, cardiac or renal disease. Any other major illness were excluded from the study. These are the result table of my study. Distribution according demographic variables. Variables were age, mode of delivery, birth weight, or gravidity. Distribution according LDH level in various group according to severity. Distribution according to maternal complications. Discussion. Total of 70 women with preeclampsia were included in this study. Severely preeclampsia patients were significantly younger with low gravidity and parity. The maternal complications were found to be maximum in women with severe preeclampsia with LDH more than 1800 international unit per liter. HELP syndrome was the most common complication. Cesarean section accounted for 58.6% of the all deliveries and 74.3% of babies born to these mothers were low birth weight. There was no case of maternal mortality. Conclusion. Lactate dehydrogenase level were found to be significantly increased in patient of preeclampsia. Maternal complications like eclampsia, abruption, HELP syndrome, perinatal complications like low birth weight were associated with the high LDH level in preeclampsia women. Thus, LDH level reflects the severity of the preeclampsia and occurrence of complications. In patients with a higher LDH level, vigilant monitoring, prompt management may decrease maternal and perinatal morbidity or morbidity. Serum LDH level can be offered to all patients of preeclampsia, can be used to predict the prognosis of preeclampsia.
I think the judges can ask questions now.
Did you measure
Yeah,
the
you can.
LDH measurements single time or repeated and found out a trend about it?
No, ma'am. This was a single time LDH.
So
level.
when was the LDH taken?
At the time of admission.
At the time of admission. What were the indications for cesarean section in this? Because these were low birth weight babies, so small babies. Why section was done?
Section done due to very high BP, uncontrolled BP. On already patient was on antihypertensive or
BP can be reduced by medical management like lobate, nifedipine, very powerful medications.
there
So
were
despite that, you mean, or
associated signs were like headache or nausea, vomiting.
impending eclampsia?
Impending eclampsia, which leads to eclampsia.
And one objective was to find out better marker. So nothing is mentioned in the conclusion, or an effort is not put for anything for that. One objective was there, a better marker than LDH.
Do we recommend doing LDH now after this study, or does it add anything to our study?
We can add other biomarkers.
See, the purpose is not going on increasing the number of investigations we order. Do they really make the difference to the management? If yes, then possibly yes, we can add. If it doesn't make the difference, or if it doesn't add to our assessment, even negative result is something which is very good. At least you can negate doing something in subsequent group of patients. So doing LDH today for next possible preeclampsia patient, will it add or will it change your assessment or decision?
It can.
If doesn't, then possibly we are not justified doing LDH. If it changes, then we are justified doing LDH.
I think Dr. Chaitanya,
yes, ma'am.
You can go back and just study the paper again. Okay.
Yes.
Or maybe you can discuss with your faculty who is doing this. Is it okay?
Okay.
Okay, you can stop sharing
Thank you,
your
ma'am.
screen. Judges, can we go to the next presenter, please? Dr. Niharika Singh. Dr. Niharika Singh is present.
Yes, ma'am. Yes.
Please.
Yes, ma'am. I'm here. I'll share.
The next presenter would be Shikesh Urmode and then Jeevan Rathod.
Hello.
Yes,
Hello.
yes, we can.
Hello. Ma'am.
Please.
Okay. Okay. Good afternoon, everyone. The topic of my research is a study of causes of thrombocytopenia in pregnancy and its effect on maternal outcome. Thrombocytopenia is the second most common hematological abnormality seen in pregnancy, first being anemia. Thrombocytopenia is defined as platelet count less than 1,50,000. If it is mild, the platelet count is between 1 lakh to 1,50,000, moderate 50,000 to 1 lakh, and severe when it is less than 50,000. The incidence of thrombocytopenia in accounting for almost 70% of all cases. Due to hemodilution secondary to expansion of plasma volume, platelet count in normal pregnancies may decrease by approximately 10%. Most of this decrease occurs during the third trimester, accounts for 21% cases. Immune-mediated thrombocytopenia, including idiopathic thrombocytopenia purpura, is responsible for 4.1% cases. Spontaneous bleeding may occur with less than 20,000 platelets per microliter, and the risk of internal bleeding is increased if the platelet count falls below 10,000 per microliter. Idiopathic thrombocytopenic purpura is an autoimmune disorder characterized by destruction of circulating antibody-bound platelets by reticuloendothelial system, particularly in spleen. In the pregnant cases, the antibody crosses the placenta, placing the infant at risk of thrombocytopenia. The present study is to study the different causes of low platelets in pregnancy in our setup and its relation to the outcome in mother. Aim is to study the cause of thrombocytopenia in pregnancy and its effect on maternal outcome. Study is carried out in antenatal outpatient and from indoor patients of the Department of Gynecology and Obstetrics of our hospital, which is a tertiary care hospital. This is a prospective observational study involving pregnant women who were diagnosed to have thrombocytopenia during pregnancy during the period of study. Pregnant women, irrespective of parity and gestational age, who were diagnosed to have thrombocytopenia during pregnancy were included in the study, and any pregnant women with known hematological disorders or thromboembolic disorders were excluded. Detailed menstrual and obstetric history was obtained. Thorough general physical and obstetric examination was done. Gestational age was established by menstrual history and clinical examination and confirmed by obstetric ultrasonography. All routine investigations along with platelet count estimation and coagulation profile, peripheral smear, dengue, IgG, IgM antibodies, liver function test, renal function test, and obstetric sonography were done to find out the causes of thrombocytopenia. Women with normal platelet count before 28 weeks had repeat platelet count in third trimester to detect gestational thrombocytopenia. All the cases are followed to record any complications like preterm labor, abruption, preeclampsia, postpartum hemorrhage, or any other morbidities to find out the maternal outcome. All information was gathered and results were analyzed. During the period of study, out of 246 pregnant patients, 40 patients were found to have thrombocytopenia with a platelet count of 1,50,000 or below. Out of 40 thrombocytopenic patients, only 30 patients were studied, as rest 10 patients did not follow up, giving a prevalence of approximately 12%. Table 1 shows the distribution of thrombocytopenia among pregnant women at different weeks of gestation, with majority in third trimester, 43% cases in 30 to 34 weeks gestation, 21% cases in 35 to 39 weeks gestation, and 3% cases in 40 weeks or more, 10% cases in less than 20 weeks gestation, 7% cases in 20 to 24 weeks gestation, and 60% cases in 25 to 29 weeks gestation. Table 2 shows distribution of thrombocytopenia according to the parity of the patient. 43% cases were primary gravida, 33% cases were second gravida, and 24% cases were multigravida. Hence, we can say parity has no significant influence on occurrence of thrombocytopenia during pregnancy. Table 3 illustrates the severity of thrombocytopenia among pregnant women. 33% had mild thrombocytopenia, 57% cases had moderate thrombocytopenia, and 10% cases had severe thrombocytopenia. Out of the 30 pregnant women who were thrombocytopenic, most of them had moderate thrombocytopenia. Table 4 shows distribution of thrombocytopenia cases according to the etiology. 53% cases has gestational thrombocytopenia, 27% cases of hypertensive disorder of pregnancy, 7% cases of HELP syndrome, 2% cases of dengue, 3% cases of ITP, that is immune thrombocytopenic purpura, and 3% cases of multi-organ failure. Table 5 illustrates the various modalities required for management of thrombocytopenia in pregnancy according to the etiology and severity. 50% cases did not require any treatment. 23% cases required corticosteroids. 3% cases required corticosteroids along with immunoglobulin therapy. 3% cases require intravenous immunoglobulin therapy as they were resistant to corticosteroid therapy, and 20% cases with either severe thrombocytopenia or acute situations require platelet transfusion. Table 6 shows the maternal outcome in thrombocytopenia in pregnancy. 73% cases had good maternal outcome with no complications. 3% mortality is associated with thrombocytopenia in pregnancy due to serious complications. 15% cases are seen to have PPH. DIC is seen in 6% cases. 3% cases are associated with other complications such as renal failure, liver failure, congestive cardiac failure, etc. Discussion. Thrombocytopenia is a widespread problem during pregnancy, often underdiagnosed and mismanaged. This study was a prospective study of 6 months, which included 246 pregnant women. Among them, 30 cases of pregnant patients had thrombocytopenia. The incidence of thrombocytopenia in this study was 12%. This figure was maximum cases of thrombocytopenia were seen in 30-34 weeks of gestation, followed by 21% cases in 35 to 39 weeks of gestation. Out of 30 cases of thrombocytopenia in this study, mild, moderate, and severe degree of thrombocytopenia was seen in 33%, 57%, and 10% cases respectively. Gestational thrombocytopenia was the most common etiological factor, with 53% cases, followed by 27% for hypertensive disorders, 7% for HELP syndrome, followed by 7% for dengue, and 3% for ITP. 50% cases did not require any treatment as the platelet count was above 50,000 per microliter. 23% cases were started on corticosteroids. Immunoglobulin therapy was given to 3% cases that were not responding to oral steroids. Combination of oral steroids and immunoglobulin therapy was given to 3% cases, and platelet transfusion was given to 20% cases with very low platelets and in acute situations. According to this study, 27% cases had complication, which included maternal mortality in 3% cases, PPH in 15% cases, DIC in 6% cases, and other complications like liver failure, congestive cardiac failure, renal failure, sepsis in 3%. Conclusion: thrombocytopenia in pregnancy may occur secondary to a variety of causes. The most common cause of thrombocytopenia being gestational thrombocytopenia, and next being hypertensive disease complicating pregnancy, with majority of patients with good maternal outcome. Diagnosis is dependent on timing of its onset, severity of thrombocytopenia, and the association with other abnormalities. Thorough history, regular antenatal checkup, and early diagnosis of thrombocytopenia in pregnancy would prevent the perinatal complication, maternal mortality. Management of pregnant women with platelet disorder requires a multidisciplinary approach and close collaboration between obstetrics and hematologists. These are my references. Thank you.
Yeah, I request judges to ask questions. You have exceeded your time. Please stop sharing the screen. Yeah, judges can go ahead with questions, please.
Which cases were given steroids for thrombocytopenia, or it was in consultation? Yeah.
Ma'am, patients with the platelet counts between 50 to 70,000, but they had no symptoms. So as the prophylactic, they were given steroid, prednisolone, mostly 20 milligram per day.
No, but only the count decided to give steroid on the counts?
Yes, sir. Hematologic consultation was done. And
that is the key, because all patients with 50 to 70,000 platelets shouldn't receive steroids, isn't it?
Yes, ma'am.
And malaria was not found out as anybody's reason, because that is again a common cause of thrombocytopenia in Indian population, along with dengue.
Yes, ma'am. In my study, ma'am, we didn't get any malaria cases. That's why I didn't include it.
And how can you say that it is the complication maternal mortality rising is because of thrombocytopenia? Because The most common cause was
No.
followed after gestational thrombocytopenia, hypertensive disorders. So that itself
No,
gives
ma'am.
rise to.
No, ma'am. Only 3% cases we showed maternal mortality. Maximum had good outcome. That is 53%, 73% cases had good outcome, maternal outcome. I have said in my conclusion. Yes, ma'am.
Only 3%.
Okay.
Yes, ma'am.
Okay. Thank you, Dr. Niharika.
Yes, ma'am.
We'll
Thank you,
go to
ma'am.
the next presenter now, Rishikesh Urmode. You start sharing your screen. I request all the presenters to stick to the time. It is 6 minutes for presentation, so that then you get 2 minutes for question answer, where you can again impress the judges.
Good afternoon, all. I'm Rishikesh Urmode from GMC Gondia. I'm presenting my research work on effect of Sudarshan Kriya on holistic health of women. Let's understand the background of this study. The worldwide priority of women's health are changing from narrow focus of MCH to comprehensive influence, leading to disturbances in their health. As you all know, holistic health consists of emotional, mental, social, spiritual, and physical dimensions. Sudarshan Kriya is a specific form of rhythmic breathing exercise which has favorable effect on mind-body system. It is also known to improve immunity, antioxidant status, hormonal status, and brain functioning. The aim of the study was to study the effect of Sudarshan Kriya on holistic health of women. Here, we are hypothesizing that SKY can serve as effective tool in managing the holistic health of women. The methodology followed. It was a qualitative cross-sectional study done on females of age group more than 18 years who agreed to participate, practicing Sudarshan Kriya for more than 2 years without a continuous gap of 3 months. The data was collected by simple random sampling. Sample size was 142. Data was collected by purposive sampling with the help of pre-tested and pre-validated questionnaire. Statistical analysis was done by summary statistics and quality analysis. These are the demographic details of the participants. With respect to education, per capita income, and occupation, this graph depicts that most of the population is educated, belonging to class 1 of SES and belonging to the service category. If we study the effect of Sudarshan Kriya on physical health, we can see through the statistical analysis that after practicing Sudarshan Kriya, there is reduced frequency of occurrence of fever, common cold, delayed wound healing, and skin problem. If we study the Sudarshan Kriya with respect to relationship and emotion handling, we can see after Sudarshan Kriya, females were able to understand themselves better, and they were also able to understand others. Positive effect with respect to emotional expressiveness and also on the control on emotion was seen. If we study the Sudarshan Kriya with respect to the time management skill, we have seen that there was improvement in the punctuality, decreased frequency of missing the deadlines, and also decreased tendency of procrastination was seen. We also found that after regular practicing of Sudarshan Kriya, females were able to complete their daily works within time. If we study the effect of Sudarshan Kriya on energy level, we found that females were complaining about feeling tired early and feeling lazy and lethargic after practicing Sudarshan Kriya, found that they are not experiencing such complaints now. If we study the work efficiency, it was found that after practicing Sudarshan Kriya, females were able to complete a great amount of tasks with limited amount of time and efforts. Also, there was feeling of well-being at workplace. and females were also females were able to help their peers with calm state of mind. With respect to menstrual problem, we have got alarming and encouraging result with p-value, significant p-value of 0.00. With respect to thyroid problems, we have again obtained p-value of 0.0. With respect to improvement in symptoms of thyroid disorder, if we study the effect on menopause, there is markedly decreased severity of symptoms. Here we can see the severity of symptoms in non-practitioner and non-practitioner, and here you can see the severity of symptoms in the practitioner, which is significantly low. Let's jump to the discussion. In this study, we have found that Sudarshan Kriya decreases the frequency of occurrence of common complaints like fever, cough, wound healing, and skin health. Dr. Sharma has also found it improves health and wellness. Some researchers have also found better positive effects on immunity. Dr. Rao has observed it on cellular level. There is significant improvement in energy levels. Researchers have found that it restores the energy and also increases the energy. With respect to work efficiency, we have got positive results. It significantly reduces the workload and enhances the work tolerance. With respect to menopause, it reduces the frequency and severity of the menopausal symptoms. Dr. Patil has suggested that it helps perimenopausal women to attain smooth menopause. There is possibility of literate.
Please conclude.
Okay. In this study, we conclude that SKY has a beneficial effect on holistic health of women. It is simple, cost-effective, and complementary therapy which improves the health and wellness of females. That's all. Thank you, ma'am.
Thank you. Dr. Rishikesh, you are UG or PG student?
Ma'am, I'm UG student.
Okay. Judges, over to you for the questions. Dr. Yenge or Dr. Varsha, can you ask the questions, please? It was on Sudarshan Kriya.
Yes,
And
I just wanted to ask two questions. What was the sample size and how were the measurements taken?
So, sir, my sample size was 142 and the data was collected with the help of pre-tested and pre-validated questionnaire. The questionnaire consists of two sets of questions for each aspects. In the first aspect, we were asking their views on the aspect study before practicing Sudarshan Kriya, and in second set, we were asking their views after practicing Sudarshan Kriya, like what they have experienced.
Fine, that is subjective. How did you differentiate between thyroid disorders pre and post, or practitioner versus non-practitioners?
So in this study, we have included the patient who had thyroid issues earlier, but they started practicing Sudarshan Kriya. So we have asked them about the changes in the symptoms that they experienced.
And they were treated for thyroid disorders or not?
Yes, sir. They were on the treatment.
Fine.
It's okay. So let's go to the next presenter, Dr. Jeevan Rathod. Please start sharing your screen. Dr. Jeevan, you are UG or PG?
PG, ma'am. Hello.
Yes.
Hello.
Yes.
Hello. Am I audible, ma'am? Hello.
Yes, you can go ahead.
Yes.
Hello.
Please start.
Hello.
Yes, you can go
Good
ahead, please.
afternoon. My study is on eco findings, assessment of risk factors, and of stroke patient. Stroke is a medical emergency. It is the third leading cause of CAD after CA and laboratory studies support the diagnosis of stroke. There is not adequate data regarding association between 2D eco findings with stroke, and so we are assessing the association between eco stroke. Stroke broadly divided into two types: ischemic and hemorrhagic type. Cardiogenic stroke or the associated with certain cardiac source, very crucial in case of ischemic stroke. For better evaluation and treatment, there are various risk factors for stroke as previous literature and studies done. Association with risk factor even after complete diagnostic workup, 30% cases remain, and most of these cases are embolic features. Aim and objective of the study to evaluate different 2D eco findings and various risk factors associated with stroke to assess differences have got any materials and methods to see the risk factor different of SPA to add in prognostic value. For 100 non-probability convenience sampling method in government medical hospital within 3 days of onset of stroke. Negative consent were excluded from the study. The stroke incidence was more common in 4th and 5th decade of the life. Total 100 patients was out of 166 were male and 34 were female. Classification of in stroke patient: hypertension, 10 patients with blood pressure, 14 with high normal blood pressure, 32 patients and 22 patients with grade 2 hypertension, and 12 patients with grade. Hypertension was the most common risk factor in stroke patient. Out of 100 samples, 12 patients are grade 2 hypertension, 22 patients with 2 hypertension, and 12 are grade 3 hypertension. Among others, 4 found high normal blood pressure. To eco finding in stroke, 17 patients with reduced ejection fraction, 52 with no ejection, and 9 patients with valvular heart disease. Out of 142 ischemic and 10 hemorrhagic patients with normal 2D patient and patient reduced ejection fraction, 7 hemorrhagic patient with diastolic dysfunction, and 7 ischemic and 2 his. Reduced ejection fraction, 17 is common abnormality in ischemic age group, whereas diastolic dysfunction is commonly seen in hemorrhagic stroke patient. Overall association between stroke and 2D echo was statistically insignificant. Incidence of risk factor in stroke patient: 12 patients with history of DM, past history of DM, and 41 came with past history of hypertension, and 13 patients with old CVA. 20 patients with smoking history, and 14 with tobacco chew, and 14 with alcoholic history. Finding in study group, patient with normal fundus examination, 17 with retinopathy. 7 patients with ischemic stroke, hemorrhagic stroke, yes, 63 and 20 63 patients with ischemic stroke and 20 with hemorrhagic stroke under 7 stroke patient, 10 patients with hemorrhage was statistically significant between stroke and retinopathy. Out of 17 patients were hypertensive retinopathy, 1 patient with hypertension with retinopathy. This out of 66 were and 34 stroke most commonly 4 and 5th most common risk factor out of 40 patients. And next second most common risk factor was common diabetes, least common with IHD patient. In this study, reduced ejection fraction ischemic stroke patient 17 valvular heart disease was present in 9% cases. 2D echo, normal 2D echo findings seen in 52%.
Dr. Rathod?
Hello, ma'am.
Yes. Yeah, Dr. Yangi, you can ask questions.
No, ma'am, nothing.
Nothing? Okay, Dr. Varsha, do you have any questions?
Yeah, the retinopathy which you have taken, is it grade 1, grade 2, grade 3, grade 4? Any correlation with the gradation, or just grade 1 also is you have taken as retinopathy?
Ma'am, I'm not mentioned that grade in the fundus examination. They're taking the fundus examination from optal, so they not mention any grades, ma'am, in that.
They have not mentioned. Okay.
Yes,
but
yes,
you yourself, you are working in which area? Emergency medicine?
Yes, ma'am. Medicine.
Medicine. So you have not done the fundus
General
examination?
Medicine. Yes, ma'am.
It's a part of examination.
No, ma'am. No, ma'am.
All right.
Okay. Right. You are a PG or UG?
PG, ma'am.
Medicine PG, third year.
Okay, can we go to the next presenter, please? Dr. Justine Daruwala. After Dr. Justine, it will be Dr. Aditya Nandedkar and Pranuti Gayakwad. Please be ready. So, Dr. Justine Daruwala, can you share your
Good afternoon, ma'am. I have signed in to Dr. Pranuti Gaikwad's account. There is an issue on network on my side.
Okay. Please share your screen.
Yes, ma'am. Yes, ma'am. Ma'am, can you see it?
Yes. Please go ahead.
Okay. One second.
Yes, your screen is visible.
Yes,
start your.
My topic for today is fetal-maternal outcome in hypertensive disorders in pregnancy. Hypertensive disorders in pregnancy is one of the most common cause of maternal mortality in India. The incidence by ACOG is 12 to 22%. It accounts for around 24% of maternal deaths. Pathogenesis, abnormal placentation, and the maternal response to it, which is multisystemic. Etiology is multifactorial. Maternal and fetal outcomes due to it. Maternal complications are, for example, preterm labor, abruption, DIC, pulmonary edema, thromboembolism, cardiac failure, HELP syndrome, renal failure, and cerebral hemorrhage. Fetal complications are preterm baby, intrauterine growth restriction, intrauterine fetal demise. Long-term complications are chronic hypertension, insulin resistance, and susceptibility of the female baby to develop preeclampsia in her future pregnancy. According to the ACOG classification, types of hypertension are as follows: Gestational hypertension, BP in that is greater than or equal to 140 by 90 mm of Hg, and it is more than 20 weeks of gestation. Chronic hypertension, that is hypertension before 20 weeks of gestation. Preeclampsia, where the BP is more than equal to 140/90, and there is either edema or proteinuria and end organ damage. Eclampsia, where there is preeclampsia along with seizures. Preeclampsia superimposed on chronic hypertension, where there's a sudden rise in blood pressure and new onset proteinuria, end organ damage. Aims and objectives: to determine the prevalence of hypertensive disorder of pregnancy, to determine the maternal and the fetal outcome in patients with hypertensive disorder of pregnancy. Methodology: it was a retrospective cross-sectional observational study which was conducted over a period of 1 year between August 2020 to July 2021 in the Department of OBGY at Ashwini Rural Medical College Hospital in Kumbhari in Solapur. Total of 61 pregnant women case records were retrospectively analyzed who presented with hypertensive disorder of pregnancy. A pro forma was maintained to record the following, that is maternal age, parity, registration status, period of gestation and diagnosis, severity, type of hypertension, associated maternal risk factors, comorbidities, types of delivery conducted, maternal and perinatal outcome, and the complications. Antihypertensive drugs that were used were nifedipine or lobetalol. Magnesium sulfate was the anticonvulsant which was used following the Pritchard regimen. High-risk cases were managed in the ICU. The data collected were coded and entered in MS Excel sheet and processed further with appropriate statistics. Results were as follows. First, we studied the age distribution. 11% of the patients, they were above the age of 30 years. 15% of the patients were lesser than 20 years of age. 30% of the patients lied between the age of 21 to 25. 44% of the patients lied in the age group of 26 to 30%. Multiparous patients were 46%, whereas multiparous were 54%, primigravidas were 46%. Gestational age at presentation, more than equal to 37 weeks of gestation were 36% of the total patients, and less than 37 weeks of gestation were 64% of the patients. Now, the type of hypertensive disorders, highest was noted in preeclampsia, that is 52.42% of the patients, and lowest was chronic hypertension, which were 4.91% of the patients. Out of the total 61 hypertensive mothers, 44 developed life-threatening complications. PPH was seen in 19.67%, eclampsia was seen in 16.39%, abruption was seen in 14.75%, 8.19 patients had HELP syndrome. All of them were successfully managed in the ICU. There was no maternal mortality. No major complications were observed amongst the 26.22% of the neonates, and all were successfully managed. Low birth weight was seen in 45.9% of the babies. IUGR was seen in 29.5%. IUD was seen in 22.95% of the babies. And neonatal death was seen in 8.19% of the babies. Apart from hypertensive disorder of pregnancy, few patients also presented with medical and obstetric comorbidities, some of which have a causal relationship with hypertensive disorders. Mode of delivery was recorded in each and every case. Out of the total patients who underwent LSCS, 23 underwent preterm vaginal delivery, 20% underwent full-term normal delivery, 7% underwent vacuum delivery. ACOG estimates that hypertensive disorders complicate about 12 to 22% of the pregnancies, and it has diverse risk factors. Preeclampsia, eclampsia is responsible for an estimated 16% of global maternal mortality annually. Hypertensive disorder of pregnancy complicated wide range of institutional deliveries from 5 to 8.5 to 8.25 to 25.1%. Multi-country survey of WHO has shown that there were 3 to 5-fold increased risk of perinatal death in women with preeclampsia and eclampsia respectively, as compared to the women with no preeclampsia or eclampsia. The fetal-maternal outcomes of hypertensive disorder affected by multiple factors like gestational age at the onset, severity of the disease, presence of multifetal gestation, and the presence of comorbid conditions including diabetes mellitus, renal disease, thrombophilia, or pre-existing hypertension, that is chronic hypertension. The perinatal mortality and morbidities such as low birth weight, preterm, SGA, small for gestational age, IUGR, need for resuscitation as well as NICU admission are substantially increased in women with severe preeclampsia. Pregnancy
Madam, please
induced.
conclude.
Yes, ma'am. Yes, ma'am. Hypertensive disorders has a significant impact on maternal and morbidity and mortality. It is very important to recognize it early through the signs and symptoms so that we can take the necessary measures like starting low dose ecosprin, aspirin, and preventing it. Thank you, ma'am.
Yeah, over to you, judges, Dr. Varsha and Dr. Yenge, sir. You can ask.
Prospective
Can
patients
you-
with pregnancy were screened and then enrolled. All those who had hypertension during pregnancy were enrolled.
Yes, ma'am. Yes, sir.
Okay, and you had how many? 64 patients total.
Yes. We had total 61 patients.
61.
So retrospectively, we observed that it was common in which age group. Was it common in primigravidas or in multiparous patients? What were the risk factors? What were the complications involving it? What were the mode of delivery? What was the neonatal outcome? So it was a retrospective study based on that. So.
सर्दी बरी झाल्यावर घेऊ ते
सर्दी बरी झाल्यावर 2 आठवड्यांनी बघू.
असं काही गरज नाही.
गरज आहे पण 2 आठवड्यांनी बघू.
Dr. Aniket Joshi, any question from you? Okay.
Not at present. No questions.
Okay. Thank you, sir.
Thank you, sir. Thank you, ma'am.
Yeah, we'll go to the next presenter. Please remember, this one was Dr. Justine Daruwala. Because of her net problem, she presented from Dr. Gayakwad's laptop. But she was Justine Daruwala. Next is Dr. Aditya Nandedkar.
Yes, ma'am, I'm
Share
here.
your screen.
Ma'am, am I audible?
Yes, you are audible, but we are not able to see your screen. So please share your screen.
Is it visible now, ma'am? Hello? Hello?
Visible.
Yes, ma'am. Shall I start, ma'am? So the top title of my study is Study of Serum Magnesium and Vitamin D3 in Type 2 Diabetes mellitus patients and its correlation with the coronary artery disease. So introduction, so there are several studies that have suggested that coronary artery disease, hypertension and type 2 diabetes mellitus are comorbidities and the major risk factors of the mortality. Incidence of these chronic diseases are growing rapidly, and identifying the modifiable risk factors is crucial in preventing these diseases. Micronutrients have recently been studied as a potential preventive and therapeutic agents for type 2 diabetes mellitus and its complications. The role of magnesium in development and progress of type 2 diabetes mellitus and cardiovascular diseases has drawn researchers' attention in the recent decades. Several large prospective cohort studies have shown that low magnesium intake is associated with the increased incidence of type 2 diabetes mellitus and coronary artery disease. Vitamin D deficiency may be overlooked, a cardiovascular risk factor among type 2 diabetes mellitus patients. Vitamin D appears to affect several metabolisms that have been associated with the coronary artery disease, such as inflammation, muscular calcification, myocyte hypertrophy, proliferation of the smooth muscle cells in blood vessels, arteriosclerosis, renin-angiotensin system, blood pressure control, and the insulin resistance. Aim of my study is to evaluate the level of serum magnesium and vitamin D3 in type 2 diabetes mellitus and its correlation with the coronary artery disease. So the methodology, we have taken 100 patients representing the internal medicine OPD of Dr. Ullas Patil Medical College, Jalgaon, with type 2 diabetes mellitus and coronary artery diseases, and its complications were included in the study. We have found the mean age of the patient was 49.1 plus or minus 9.6 years. A slight male preponderance was there. A male to female ratio was 1.32:1. Majority of the patients belong to the age of 40 to 49 years of age. This is the age distribution based on the gender. Mean serum magnesium levels were 1.74 plus or minus 0.38. 55 patients had normal magnesium levels. Hypomagnesemia was found in 45 patients. 27 were males and 18 were females. Mean serum vitamin D3 levels in study population was 21.9 plus or minus 6.7. 49 patients had deficient vitamin D3 levels and 51 had normal levels of vitamin D3. This is the distribution of the serum magnesium and vitamin D3 based on the gender, which we have seen earlier. This shows the distribution of the magnesium and vitamin D3 based on the gender in the bar diagram. Ma'am, we have found statistically significant difference between the patients with the normal serum magnesium levels and the patient with low serum magnesium levels for the duration of diabetes and HbA1c levels. Lipid profiles of these patients were also deranged compared to the patients with the normal serum magnesium. This shows the distribution of the various clinical and biochemical parameters with the serum magnesium levels. The factors which are responsible for the complications, including serum cholesterol, triglycerides, LDL, HDL, VLDL, and again fasting blood sugar. Distribution of the various clinical parameters with the serum vitamin D3. When compared, ma'am, patients deficient in the vitamin D3 had poor glycemic control, long duration history of diabetes, and the worsened lipid profile as compared to the patient with normal vitamin D3. This shows the distribution of the various clinical and biochemical parameters with the serum magnesium levels. So the discussion, vitamin D3 deficiency is a common worldwide problem. The association of the low vitamin D status, the numerous chronic diseases as type 2 diabetes mellitus, cardiovascular diseases, cancer, and the autoimmune diseases already established. The several studies have reported that the serum 25-deoxydeoxylase levels were lower in the patient with type 2 diabetes mellitus compared with the healthy individual. The authors have found that the level of HbA1c in the is higher in patients with type 2 diabetes mellitus who have vitamin D deficiency. Type 2 diabetes mellitus is a major risk factor for coronary artery disease, which is a leading cause of death amongst these patients. Type 2 diabetes mellitus has many complications where hyperglycemia contributes to the complications. The diabetic control and the complication trial determine that the hyperglycemia increases the development of diabetic microvascular complications in patients with diabetes. The glycemic control plays a key role in a decrease in the risk of all the diabetic complications, mortality, and morbidity because of cardiovascular disease in patients with diabetes. Moreover, there was a relationship between high prevalence of vitamin D deficiency and prevalent cardiovascular disease in type 2 diabetes mellitus patients. Study investigated the correlation between vitamin D deficiency and the cardiovascular diseases in healthy individuals and the patients with type 2 diabetes mellitus. They observed the severe vitamin D deficiency is associated with the increased cardiovascular mortality. In our study, we observed that the fasting glucose and the HbA1c were higher in diabetic patients with the vitamin D deficiency and higher triglycerides and the cholesterol that contribute to the increased cardiovascular mortality. Overall, the vitamin D deficiency has been found to contribute to the various cardiac conditions such as hypertension, cardiovascular diseases, stroke, atherosclerosis in diabetic patients. In the present study, the serum magnesium concentrations were below the reference range in 45 patients with the type 2 diabetes and normal in 55 patients. This confirms to the reported prevalence of low plasma magnesium status in type 2 diabetes in several studies, which range from 25 to 39%. The serum levels of magnesium have been found by several investigators to correlate inversely with the fasting glucose, postprandial glucose, and the percentage of HbA1c. The present study also revealed that the patients with the low serum magnesium levels had poor glycemic control. There was a statistically significant association between the low serum magnesium levels and the higher FBS and the HbA1c. So in conclusion, from above findings, we can conclude that the coronary artery disease was significantly associated with the vitamin D deficiency among the diabetic patients. Diabetics with the vitamin D deficiency were 1.5 times higher having chances of coronary artery disease compared to the diabetics with the normal vitamin D level. Similarly, diabetics with the low serum magnesium deficiency were 1.3 times higher chance of coronary artery disease compared to the diabetics with the normal serum magnesium level. In present study, the sample size was small, so we would like to investigate further with a larger sample size. These were my references, ma'am. Thank you, ma'am.
You have found out the relation between the IHD and DM and serum magnesium, but about
Yes,
the
ma'am.
diagnosis of IHD, how have you determined?
Ma'am, we have taken 2D echography, ECG findings as well as coronary angiography findings, ma'am.
Okay, so because that was not mentioned in the observation,
Yes, ma'am.
that's why this question arises.
Yes, ma'am. We have confirmed the ischemic heart disease with all the three investigations, ma'am.
But ECG, was it only ST elevation MI or ischemic changes, or because
no, ma'am.
ACS
Both.
is a big stratum which
Yes,
includes
ma'am.
everything. So
Yes, ma'am. Ma'am, we have included common group of patients in having ischemic heart diseases. All those in this study, ma'am, we could not evaluate the patients with the acute coronary syndromes. We have mostly taken patients who have been diagnosed with ischemic heart disease previously and have been on treatment on a regular basis.
This was not ACS, and all previously documented coronary artery disease was the cohort.
Yes, ma'am. Yes, sir. Yes, sir.
So will you do vitamin D level for and magnesium level for all your patients subsequently now?
Yes, sir. We are planning to do it in our institute, but the problem is, sir, with the investigations, they are costlier now. Vitamin D and
Yes,
magnesium
and
sometimes.
the more importantly, will you actually consider treating them based on the present findings?
No, sir. The sample size is quite smaller, sir. We would like to further investigate the relation and how it would affect the outcome.
Yes, at the most we can say this is a hypothesis generating study. The sample size is too small for making any conclusive decisions. On top of that, we are yet to prove that the treating them actually is going to possibly decrease the risk of recurrence or something. Unless that is done, I don't think this is practice.
Yes, sir. Vitamin D and the magnesium are not being treated currently to prevent the progression of the disease, but there is certainly a relation between the progression of the disease or arising of the complications with the vitamin D and the magnesium, sir.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Aditya. Please stop sharing your screen. And I
Yes, ma'am.
request now Pranati to share her screen. And next would be Dr. Harshad Jain and Mruganeni Namdar to keep their presentations ready.
Hello. Ma'am, can you hear me?
Yes, I can hear you and I can see your screen. You can start presenting by going on to the slideshow mode.
Yes, ma'am. Good afternoon, respected judges. I'm Dr. Pranati Gaikwad. My today's topic is a study of thrombocytopenia in pregnancy and its fetal-maternal outcome in rural tertiary care hospital. Platelet count below 1.5 lakh per cubic millimeter is called thrombocytopenia. After anemia, it is the second most common hematological disorder in pregnancy. It affects nearly 6% of 6 to 15%, on average 10% of all pregnancies. Thrombocytopenia is categorized into mild, moderate, and severe. Mild is when the platelet level is 1 lakh to 1.49 lakh. Moderate is moderate when the it's between the 50,000 to 1 lakh. And the severe thrombocytopenia when the platelet count is less than 50,000. In a normal pregnancy, 7.6% of women present with mild thrombocytopenia and 65% of them will not be associated with any pathology. Normal pregnancy is associated with physiological fall in platelet count that is characterized by a leftward shift in the platelet count distribution. These changes may reflect dilution, decreased platelet production, or increased platelet turnover during pregnancy. Fall in the platelet count during normal pregnancy results in some pregnant women developing platelet counts that fall into the thrombocytopenic range. And because of that, there is no diagnostic testing available of gestational thrombocytopenia. This disorder is a diagnosis of exclusion. It resolves spontaneously after the delivery. Thrombocytopenia in pregnancy can be due to other obstetric disorders like hypertension disorders of pregnancy, such as preeclampsia, eclampsia, and its complications such as HELLP syndrome, abductio placenta, and which leading to disseminated intravascular coagulation. Medical causes like thrombotic thrombocytopenic purpura, TTP, hemolytic uremic syndrome, autoimmune disorders, systemic lupus erythematosus, ITP, antiphospholipid syndrome, infection, sepsis, hypersplenism, and the primary bone marrow dysfunction. Other causes are spurious or pseudothrombocytopenia or drug-induced thrombocytopenia. The pregnancy is associated with numerous metabolic, immunological, and other homeostatic changes that require careful consideration when attempting to define the cause of thrombocytopenia in a particular individual. Identifying the leading pathological condition and timely management to enhance the fetal-maternal outcome should be the prime importance. Aim of my study is the study was conducted in a rural tertiary care hospital to study the prevalence of thrombocytopenia in pregnancy. Objective is to analyze the etiology of thrombocytopenia in pregnancy and to analyze the fetal-maternal outcome of thrombocytopenia. In inclusion criteria, I included all pregnant women with platelet count less than 1,50,000 in this study and the pregnancy with previous history of ITP. In exclusion, the pregnancy of the pregnant or non-pregnant women having diabetes or thromboembolic disorders were excluded, and the women with collagen disorders, tuberculosis, autoimmune diseases, epilepsy or seizure disorders, previous bad obstetric histories, and leukemias were excluded. In the methodology, the area of study is Ashwin Rural Medical College, Kumbhari, and the duration of study is 1 year from August 2020 to July 2021. The type of study is a hospital-based retrospective observational study. And the parameters studied in these are the blood test for hemoglobin, TLs, total leukocyte count, differential leukocyte count, bleeding time, clotting time, RFT, LFT, HbS, AG, and HIV. And women with fever were tested for dengue, IgM, rat, and the malaria parasite. Coagulation tests where PT and APTT were done with the patients having signs of DIC. The results in this study, out of 360 pregnant women, 30 patients had a platelet count of less than 1.5 lakh, and the 330 women had a normal platelet count. Thus, the prevalence of thrombocytopenia in pregnancy is 8.66% in the tertiary rural care hospital which are studied. Among these, 17 patients had gestational thrombocytopenia, 7 patients had preeclampsia, eclampsia, HELLP, 3 patients had viral fever like dengue and malaria, 2 patients had ITP, and the patients had and the 3 patients had abruptio placenta or DIC, and the 1 patient had COVID-19 infection. This is the pie diagram. It's showing the various causes of thrombocytopenia in a tertiary care hospital, and it is showing the maximum proportion of a gestational thrombocytopenia, which is 47%, and next to that is hypertensive disorder, which is 23%. The other minor causes are viral fever, ITP, COVID-19, and DIC. Second table in which I'm showing the distribution of thrombocytopenia according to severity of the thrombocytopenia, which is categorized into mild, moderate, and severe. Again, in this is the chart which is showing the gestational thrombocytopenia. The mild is showing by the blue and the moderate is by the orange. The gestational thrombocytopenia is showing the equal proportion of the mild to moderate pattern of thrombocytopenia, while the cases like ITP is showing the severe, which is the platelet count less than 50,000. And in the cases of COVID-19, the observed thrombocytopenia was mild in nature. The study showed out of 30 babies, delivered, 2 of them showed fetal growth restriction, 1 had birth asphyxia, and no cases of intracranial hemorrhage among these babies have been observed. There was a single incidence of neonatal thrombocytopenia. Neonatal thrombocytopenia is seen in the patients with immune thrombocytopenia, in which antiplatelet antibodies are transferred to the fetus with the placenta, and rest all neonates had normal platelet count at the birth. And the perinatal mortality was observed in the cases of fulminant eclampsia or the DIC cases. In our study, 6 patients required MICU care and the platelet transfusion and close monitoring for bleeding symptoms. There were the maternal near miss events, 20%. There were mainly cases of eclampsia, abruptio placenta leading to DIC and ITP. Platelet transfusion given in this patient has been proven life-saving. The case of ITP has been given methylprednisolone to keep her platelet values above 50,000 as a cutoff to proceed for the cesarean section, which had been done for her obstetric cause and not for her medical condition. In this discussion, I would like to say that gestational thrombocytopenia, the most prevalent cause of pregnancy-related thrombocytopenia, and is associated with, yes?
Please conclude.
Okay, ma'am. My conclusion is the baseline low platelet counts and the declining trend with increasing gestational age predispose Indian women to increased risk of thrombocytopenia in pregnancy. Thus, platelet count estimation should be a routine in the antenatal care. And the management of patients and management of pregnant women with platelet disorder requires a multidisciplinary approach and close collaboration with the obstetrician, neonatologist, and the physician. Thank you.
Judges can ask the questions. Any questions? No questions from Dr. Yenge. Any questions? We'll go to the next present.
Which have almost similar results in the same conference. 360 odd patients, 10% of the patients with thrombocytopenia, roughly 8 and 12 respectively, which comes nearly to 10%. So it just says that both studies are representative. That's all.
Yes, sir.
Thank you. Let's go to the next presenter, Dr. Harshad Jain. Please share your screen. Dr. Harshad, you are a UG or PG? Please tell me, because there will be different prices for UG and PG.
PG. Ma'am, myself, PG student, medicine resident.
Okay. Please go ahead with your screen share. Yes.
Am I visible?
Yes, we can hear you. We can see your screen. Please go on to the slide show. Yes, perfect. Start.
Good afternoon, dignitaries. Myself, Dr. Harshad Jain, medicine resident from Ashwini Hospital, Kumbari, Solapur, presenting on the case series of the correlation between the coronavirus disease presentation and HRCT chest correlation at the time of the admission. We are very much correlated with the word COVID-19 since last 2 to 3 years, which is since the millions of the cases we have found till now, its diagnosis and treatment remains a mystery till now. Its virus transmission and highly contagious nature cause it's highly transmissible and cause a pandemic throughout the world. Its clinical spectrum vary from asymptomatic cases to asymptomatic to highly ICU admission needed, such as respiratory failure and septic shock and multi-organ failures. As we all know, early diagnosis is a key to prevent the mortality and morbidity related to any disease. But in case of the COVID-19, along with the early diagnosis, timing of the investigation and treatment is the foremost important. Clinical presentation of the COVID-19 is ranges from symptomatic to mild symptom cases like the fever, cough, or throat. Severe cases might be presented at the pneumonia and decrease in oxygen saturation. The pulmonary involvement is the most common factors we all know in it, and which is given the most important diagnostic as well as the prognostic factor during its pandemic. We all know RT-PCR is one of the most common test for its diagnosis, but during pandemic state, it takes 48 to 72 hours. So we decided to study the HRCT test as a guiding to early diagnosis and early management of the disease. Aims of my study is to study the correlation between the clinical presentation of the HRCT test with the COVID-19 positive patient at the time of the admission. Methods were the retrospective study conducted on the 25 patients at the ARMC Kumbari Solapur during the duration of the 1 month, in the month of May 2021. All patients were the above 18 years with the HRCT test done on the same day of the admission. Patient with the congenital heart disease and lung disease were excluded. The results were the symptoms, most common symptoms were the cough, breathlessness, fever, myalgia, and sore throat and abdominal discomfort were the common symptoms, whereas loose motion have presented typical symptoms. My cases, I have divided the cases on the depending on the presentation and depending on the scan. According to presentation, cases were divided into mild cases, moderate cases, severe cases. In the mild cases, we conclude the upper respiratory tract infection plus minus fever or with no shortness of breath. In moderate case, we have included the patient with which have the respiratory rate more than 24 with or without shortness of breath and and SpO2 less than 93 but more than 90 at the room air. In severe case, include the respiratory rate more than 30 and with shortness of breath and its saturation less than 90% at the room air. Depending on the CT scan, we divided same into normal scan, mild scan, moderate scan, severe scan. Normal scan has a score 0, moderate scan has a score of the less than 7, for moderate scan score of the 8 to 17, and for severe scan more than 17. So in this study we have seen that there are actually
Hello.
Hello.
हाँ मैडम बोलिए.
The coma
Hello?
according
Dr. Aditya, can you mute yourself?
The patient with the diabetes and hypertension.
आपकी मैडम OTP आ ही नहीं रही है मुझे, मैं कब से वेट कर रहा हूँ.
Which have the presented at the moderate to severe
अभी
cases.
भी नहीं आया, मैं 2 घंटे से वही वेट कर रहा हूँ. आपने जो बोला है मैं कब से मैसेज कर रहा हूँ, एक भी ऐसा मुझे OTP वाला आया नहीं है.
In case of the case details, according to in our study, in my study, I have concluded
आपने
that
नंबर वही डाला है ना, आना तो चाहिए मैसेज.
each patient presented at the mild case.
Just a moment, Dr. Harshad. Dr.
Yes.
Aditya, please mute
आप नंबर
yourself.
दोबारा लिख लेंगे प्लीज.
Dr. Aditya, please mute
9145
yourself. Dr. Aditya, please mute yourself.
9546.
यही नंबर है.
तो इस नंबर पे तो नहीं लग रहा है, मैं सबसे वही कर रहा हूँ.
Please mute Dr. Aditya. I
आपने अभी
request
दोबारा
all
भेजा
other.
क्या?
Hello.
I request
जी, अभी
all
भी नहीं
other
आ रहा है.
delegates to mute themselves.
Hello. Should I continue?
ठीक है, आप दूसरा नंबर लिख लीजिए. 93
Should I continue, ma'am?
225 34 186 93225 34186.
Dr. Aditya, can you hear me, Dr. Aditya? Okay, Dr. Harshad, you go ahead. I'll just remove him from the meeting.
Yes, ma'am. In my,
Yeah.
case study, ma'am, I have seen the total 6 patients were presented at the mild case, of which 2 have the normal scan, 1 have the mild scan, 3 have the moderate scan. Among 4 patients were presented at the moderate case, and all of the 4 have the moderate scan. Among the severe cases, total 15 patients were presented at the moderate severe cases, of which 2 have the mild scan, 5 have the moderate scan, and 8 have the severe scan. According to the scan wise, around 92% patients have the typical scan of the pneumonia, while 8% patients have the normal scan. The many literature suggested that the presence of the risk factor increases the severity of the disease and so the prognosis of the disease. In our study, we have found the same number of risk factor increases, the CT severity score also increases, and so the prognosis. Similarly, in case of the HRCT plays an important role in assessing the lung condition. The HRCT test shows the typical pattern of the pneumonia, which will help you in the early diagnosis and treatment of the disease. But HRCT has the lack of the specificity, so we require the diagnosis to be made on the multifactorial basis, such as the image demonstration, clinical symptom, and epidemiological history. In our study, the sensitivity of the HRCT test for detection of the COVID-19 were 92%, which is consistent with the 97% of the study done by the AI and it all. Conclusion, my study shows the cough is the most common presentation, which comprises of the 76%, followed by shortness of breath, which consists of 56%, followed by fever, which consists around 50%. In my study, we have also concluded that as the number of risk factor increases, the CT severity score increases, and we have more the case which presented the more severe case where have the more severe scan. But in case of the mild and moderate cases presentation, we have difficulty in establishing the correlation. So HRCT have the typical, we all know the HRCT shows the image regarding the lungs have typical imaging. So it's in early screening of the highly suspected cases and early evaluation of the cases, and so the prognosis of the disease to prevent mortality related to it. HRCT, we have already discussed that have high sensitivity around 90 to 92% as compared to gold standard diagnostic test of the RT-PCR. So the COVID-19 and adding HRCT to early diagnosis, it's improves our diagnosis accuracy of the patient. So as the COVID-19 is fatal and highly contagious, so based on the basis of the HRCT test, we get help with the HRCT to triage the patient, guide our treatment, and monitor the disease and its progression and the treatment. So these are my references. Thank you.
Thank you, Dr. Harshad, and very sorry for that disturbance. Over to you, Dr. Yange, for the questions.
Do you think we should be doing CT at admission for all patients?
No, sir. Actually, we never do that. But at the time of the pandemic, at the RT-PCR used to take 48 hours to 72 hours. We study HRCT as a guiding tool to triage the patient and for early diagnosis and treatment of the patient and to prevent the further transmission from them. So we concluded this study.
Okay, so what is the utility of doing CT in your opinion?
Actually, HRCT should be done on the after 4 to 5 days of the symptoms onset and before 10 to 12 days of the symptoms.
Why? Do all patients with COVID need CT?
No, not all patients need CT.
Okay, if done at the time of admission, what will it add to your assessment?
It gives the false positive results, false negativity.
Negativity, okay, it can give false negativity. But if patient is really symptomatic, then the sensitivity of CT you said is very good.
Around 90%.
If it is CT which is showing no features of pneumonia, possibly you can rule out COVID.
Yes, more chances,
The
sir.
specificity is not very good.
We are not completely rule out the COVID, but as I already discussed that it should be on the multi-diagnostics basis. That's clinical presentation, imaging, and epidemiological history. So that. Okay.
Okay, ma'am. Thank you.
Thank you. Thank you, sir.
Thank you, Dr. Harshan.
Thank you, ma'am.
You can stop sharing your screen. Our next presenter is Mruganeni Namdar. And after that, Fauzan Bia. I request all others to keep their audios on mute. It disturbs the presenter when you speak loudly and you have not muted. So please keep your audios muted. Yes, we can see your screen, Mruganeni, and
Yes,
go to slideshow and start.
Ma'am, I have logged in from Dr. Pranuti Gaikwad's account, but I am Dr. Mugneni Namdar.
Yes, it's okay. Please go. Yes, please go ahead.
My topic is a study of maternal and perinatal outcome in twin pregnancy. Multiple pregnancies accounts for 3 to 4% of the births globally, though the incidence rate appears to be variable among different parts of the world. Increase in the use of assisted reproductive techniques and the increasing maternal age at birth are probably the major causative factors for the increase in the incidence. Twin fetuses usually result from fertilization of two separate ova, dizygotic or fraternal twins. Less often, twins arise from single fertilized ovum that divides, that is monozygotic or identical twins. The risk of maternal mortality is approximately 2.5 times higher in twin than in singleton pregnancies. Early and accurate prenatal diagnosis, detection and management of maternal and fetal complications are the major priorities in the management of twin pregnancies. This study is conducted to assess the maternal and perinatal outcome in twin pregnancies. The aims and objective of my study are to study the maternal and perinatal outcome of twin pregnancies, to find out various factors that contribute to adverse perinatal outcome. Materials and methods. The study area was Ashwini Rural Medical College and Research Center, Solapur. The duration of the study, it was a 1-year study from September 2020 to 2021. It was a retrospective observational study. The inclusion criteria was all pregnant women carrying twins and delivered at an institute, conceived spontaneously or with treatment were included. Exclusion criteria, pregnancies with triplets and higher order multiple pregnancies were excluded. Materials and methods. Data was collected from hospital records regarding maternal age, parity, whether spontaneous or assisted conception, gestational age, family history. Details of maternal and fetal complications that occurred during the antenatal period, labor, as well as mode of delivery were collected and analyzed. The presence of fetal risk factors like intrauterine growth restriction, twin growth discordance, fetal anomaly, cord prolapse, and fetal distress were also noted. The data was entered in Excel sheet and then results were obtained. A total of 30 twin pregnancies were studied. My results were as follows. Out of the total 30 pregnancies, 33% of the patients were booked and 67 were unbooked. 53% of the patients were second gravida, 34% were primigravida, and 13% were third gravida. The different types of twins were as follows. 60% were dichorionic diamniotic twins, 26.6% were monochorionic diamniotic, and 13.3% were monochorionic monoamniotic twins. Out of the total 30 pregnancies, 5 patients conceived with artificial reproductive techniques, 3 being ovulation induction, 1 being through IUI, and 1 through IVF. According to the mode of delivery, 67% of the patients underwent cesarean sections and 33% vaginal delivery. The most common indication for cesarean section was found to be malpresentation, which was followed by previous cesarean section, fetal distress, severe preeclampsia, and non-progression of labor. The maternal complications found in the study were preterm labor, which was 30%, PPH was 23.33%, hypertensive disorders was 20%, anemia was 13.3%, preterm prelabor rupture of membranes was 10%, and malpresentation was 10%. In the fetal outcome, 45 live twins were delivered. Out of them, 35 had NICU admission, 30 had prematurity, 10 were low birth weight, and 5 were IUGR babies. The most common cause of neonatal death was found to be respiratory distress syndrome, which was 54%. Intraventricular hemorrhage was 27.2%, and septicemia was found in 18.1%. The study had one twin pregnancy complicated with twin-twin transfusion syndrome and one with single fetal demise. Discussion. In my study, the number of unbooked twin pregnancies was more than 67%, because ours being a tertiary care center and hence referral from the periphery was more. In this study, maximum patients were second gravida 53%, 34% were primaries, and 13 were third gravida. These results were consistent with a study conducted by Singh and Chaudhary, in which the incidence of twins in multigravida was 70.7% and 64.2% respectively. The cesarean section rates in the study were more, which is 67%. This was consistent with a study conducted by Shetty. The increase in the use of a cesarean section to deliver twin pregnancies may be due to increased incidence of other obstetric indications for cesarean deliveries, such as hypertensive disorders, malpresentation, cord prolapse, and premature rupture of membranes. In the study, 60% were dichorionic diamniotic pregnancy, comparable to a study by Radhakrishnan. The various maternal complications seen in the study were the most common being preterm labor, PPH, hypertensive disorders, anemia, and malpresentation. The most common cause of death was in neonates was respiratory distress syndrome. Conclusion: determination of chorionicity at the earliest and with proper antenatal care is essential to decrease the complications, especially in monochorionic twins. Complications in twin pregnancies can be prevented by averting preterm deliveries by combined measures like good rest, cervical encerclage when incompetence is suspected, tocolysis, prevention of maternal complications like anemia and preeclampsia, administration of steroids in preterm labor by institutional delivery, and good neonatal intensive care. Planning the time and mode of delivery in complicated twin pregnancies, managing its consequences are crucial steps leading to a higher probability of successful outcome. These are my references. Thank you.
Thank you, Dr. Mruganeni. You were perfect in your timing. Over to you, Dr. Varsha Madam and Dr. Yange sir, for your questions.
Good presentation.
Thank you, ma'am.
Really nice presentation. Very well done. And what I would like to say that the conclusion need not have the solutions for visual management. Conclusion should end at your observations and the aim, how it was fulfilled by your study. So that is the only suggestion. It will not affect your performance. We are really well and very fluent presentation.
Thank you, sir.
Very nice.
Can I ask one question?
Yes, ma'am.
What's your name?
Mruganeni Nanda.
Mruganeni. Yeah, from which college you are?
Ma'am, I'm from Ashwini Rural Medical College, Solapur.
Okay. And what is the incidence of os tightening which is being done for twin pregnancies in your college?
Ma'am, we do not do it prophylactically, but since if we find a short cervix, we do it, but prophylactically it is not done.
For even for IVF pregnancies, I don't think it is advisable nowadays.
Yes, ma'am. We don't do it prophylactically.
Okay. And what is the proper indication of os tightening in the present era?
Ma'am, when there is a short cervix of less than 2.5 centimeter, and if funneling is seen, then we can do os tightening.
That is the important answer. Funneling should be seen, and it should be documented on the sonography.
Yes, ma'am.
Yes. Okay.
That's great, Dr. Mruganeni.
I don't have a question, but I have a comment. I think you're going to get a job offer if you are planning to come to Pune.
Thank you, sir.
Yeah.
Very good.
We'll go to the next presenter, Fauzan Bia. And now I take your leave, and my colleague, Dr. Ananta Kulkarni, will take over. Dr. Ananta, please. Please stick to 6 minutes time. Mruganeni was perfect in that.
Dr. Fauzan Bia.
Hello.
Okay.
Hello. Ma'am, am I audible? Hello.
Please start. Yeah.
Yes.
Yeah. Good evening, everyone. My topic for paper presentation is coronary angiographic finding between diabetic and non-diabetic patient in coronary artery disease patients. Introduction. Diabetes mellitus is one of the commonest disease. More than 100 million population is affected with diabetes worldwide. The cardiac affliction is most common cause of mortality among the diabetics. The dyslipidemia is the second most critical element in type 2 diabetes mellitus. Coronary artery disease account for the major chunk of mortality in diabetes. 9.5 to 55% of diabetic patients has reported the prevalence of coronary artery disease. The prevalence of coronary artery disease has been observed within 1.6% to 4.1% of total general population. Diabetes is the predominantly disease of cardiovascular system and is termed as diabetology. Type 2 diabetes mellitus can be perceived as an independent risk factor for heart disease as well as stroke. Type 2 diabetes mellitus patient without having any history of coronary artery disease have found an equal proportion of cardiovascular disease risk as the patient with previous myocardial infarction. Interventional cardiology serves as a diagnostic as well as therapeutic aid in the systemic evaluation of coronary artery disease. Coronary angiographic and arteriography are being remained as a gold standard technique for diagnosing and evaluating the coronary artery disease. The aim of my study is to compare the coronary angiographic findings between diabetic and non-diabetic patients in coronary artery disease. It is a retrospective study which consists of 100 patients, which were 50 of were diabetic and 50 were non-diabetic. It was considered conducted in my tertiary care hospital. Patients were included who fulfilled the inclusion criteria, and it was conducted around for 1.5 years from December 2020 to May 2022. The inclusion criteria consists of two groups, that was a diabetic group and a non-diabetic group. In diabetic group, the previously known diabetic or first time detected diabetic patient by American Diabetic Association criteria presenting with ACS. The second group was the case presenting with ACS that is non-diabetic or does not fulfill the ADA criteria. Exclusion criteria include the patient having hypothyroidism or who were previously on anti-hypolipidemic drugs. Investigation performed in this patient was fasting blood sugar, random blood sugar, HbA1c, CBC, RFT, lipid profile, cardiac enzymes, echo, ECG, treadmill test, and coronary angiogram. The patient coming with acute chest pain, breathlessness were diagnosed to have ACS. RBS and fasting blood sugar were done for all the patient. HbA1c was sent for the patient whose RBSL or fasting blood sugar was higher in the range to confirm newly detected diabetes, and in all the diabetic patients who known to have glycemic control. Coronary angiography was performed by standard Judkin's technique. Statistical analysis, the categorical data was expressed as number and percentage. Chi-square test was used to determine any significant difference between the two groups. The p-value less than 0.05 was considered as significant. The results were the 100 patients were considered, in which there were 50 diabetic and 51 non-diabetic. The mean age of patient presenting with diabetic was 49.56 years, while of non-diabetic was 47.63 years. In diabetic group, there were 31 male and 19 female, while in non-diabetic, there were 29 male and 21 females. These are the results. As you see, the disease severity increases as the duration of diabetes increases. If the patient is having diabetes for more than 10 years, the triple vessel disease is more common as compared to single vessel disease. Second is according to the severity of lesion. As a severe diabetic patient has more severe lesions, that is grade 4 and grade 5 lesions, than with non-diabetic. Non-diabetic usually have grade 1 or grade 2 lesion. It affects the management part also. The vessel involved are the triple vessel disease is involvement pattern is more common in diabetics as while it is less common in non-diabetics. The most common artery involved in both was left anterior descending artery, Second most common was left main coronary artery, but the most more affliction was in the diabetic patient, that was 84%, while in non-diabetic it was 82%. The management part also changed because due to patient having more severe lesions and triple vessel disease, the diabetic most commonly had to do the coronary bypass, while the non-diabetic could be managed by PTCA or medical management. Discussion. The incidence of triple vessel disease was significantly higher in diabetic for more than 10 years. The findings are significantly aligned with the results study carried out by Fox et al. And Singh and Niaz. Henry et al. Showed that the patient with diabetic had moderate stenosis, which is similar to the study. South et al. Also supported the findings of Henry et al. The most common vessel was left anterior descending within both the groups, along with LCX and right coronary artery. The findings were provided similar results in other studies. Conclusion is that the higher proportion of severity and extent of coronary artery disease has been addressed among the diabetics as compared to the non-diabetic. The severity of stenosis and total occlusion of the vessel is also more common in diabetic as compared to non-diabetic. The severity of the disease, that is triple vessel disease, increases significantly if the duration of diabetes is increased. The fourth is the majority of the diabetic patient with ACS has preferred CABG as the key mode of treatment for managing the different health issue. It is suggested.
Time is over. The time is over. Conclude fast.
Yeah, it is suggested to the people for taking a routine checkup and HbA1c level for measuring implication of lifestyle changes and medication, so the people could decrease the cardiovascular complication. So these are my references. Thank you.
Thank you, Fauzan. Any questions from judges? Okay, if there are no questions, we go to the next candidate, that is Partha Shah. Are you ready, Partha Shah?
Yes, sir. Good afternoon, sir.
Okay.
So I'm just sharing my screen. Good afternoon, sir. Is my screen visible?
Yes.
Can I start my presentation?
It's visible.
Yeah.
Visible,
Okay.
yeah.
So I'm starting my presentation on venous thromboembolism, paper presentation of paroxysmal nocturnal hemoglobinuria. So introduction, venous thromboembolism encompasses a DVT and pulmonary embolism and causes cardiovascular death and disability, as well as the psychological illness and an emotional distress to the patients. In a Canadian study, almost half of the pulmonary embolism patients at 1 year had exercise limitation, decreased walking distance, or dyspnea, which lowered their quality of life. The common causes of DVT and pulmonary embolism are factor V lead-in mutation, protein CS deficiency, hyperhomocystinemia. When the deep venous thrombi detach from the site of the formation, they embolize to the vena cava, right atrium, right ventricle, and lodge in the pulmonary arterial circulation, thereby causing acute pulmonary embolism. PNH is an acquired chronic hemolytic anemia characterized by persistent intravascular hemolysis with occasional or frequent recurrent exacerbations. Includes a triad of hemolysis, pancytopenia, and venous thrombosis. The shortage of GPI is due to a somatic mutation in an X-linked gene known as PIGA, required for an early step in the GPI biosynthesis. The definitive diagnosis of PNH is based on the demonstration that a substantial proportion of the patient's red cells have an increased susceptibility to the complement C due to the deficiency on their surface of protein CD55 and 59 that normally protect the red cells from the activated C. So the inclusion criteria was all the males and females more than 18 years of age who are willing to give an informed written consent. The patient should not have a known hypercoagulable state, no history of any comorbidities, trauma, or surgery done in the past. So coming to the case one, he was actually a 36-year-old male Driver by occupation came with the complaints to the casualty with left lower leg pain since the last 2 days, swelling over the calf of the left leg since 2 days, sudden onset breathlessness since the last 5 hours. The patient did not have any history of fever, cough, trauma, any major surgery or prolonged immobilization, no significant past history, addictions, chronic alcohol. On examination, the vital parameters were pulse 142 per minute, blood pressure 80 by 50 millimeters of mercury, respiratory rate 34 per minute, saturation 79% on room air. That clearly shows that the patient was in a cardiogenic shock and he was hemodynamically unstable. ECG was suggestive of complete RBBB pattern. Systemic examination, the respiratory system was air entry was equally on both the sides and no other obvious abnormalities detected. Local examination, redness, swelling, and increased warmth of the left leg. So the laboratory parameters were the hemoglobin was 8.2 grams per deciliter, LDH was raised 768, D dimer was raised 4120, serum homocysteine was raised, the normal value being less than 20. The lower limb Doppler was suggestive of acute thrombosis of the iliac femoral vein and the popliteal vein of the leg. CT pulmonary angiography was done. It was suggestive of massive embolism extending into the main pulmonary trunk. 2D echo, McConnell sign was positive. Flow cytometry was done. It was suggestive of CD55 and 59 negative. Case 2, 46-year-old male, watchman by occupation, came with the similar complaints of right lower leg pains in 6 days, swelling over the right legs in 6 days, and breathlessness in the last 2 days. The same patient did not have any history of fever, cough, trauma, or immobilization history. The no significant past history was there, and even addictions. The patient was a tobacco chewer and an occasional alcoholic. Here, the patient was vitally stable, but the pulse being 106 per minute, BP 110 by 70 millimeters of mercury, RR 22 per minute, saturation 89% on room air, and ECG suggestion of S1, Q3, T3. The other systemic examination was no abnormality detected, and local examination, redness, swelling, and increased warmth over the right leg was seen. In this, the hemoglobin was again 8.6, that's mild anemia. LDH was raised 1068, D dimer 3120. The homocysteine was raised. Lower limb Doppler suggestive of the thrombosis of the femoral popliteal and the saphenous vein of the right side. CTPA was suggestive of submassive embolism. 2D echo within the normal limits, but flow cytometry was CD55 59 negative. Case 3 is a 42-year-old male, driver by occupation, with complaints of only the left lower limb DVT. There was and low-grade fever since the last 2 days. The patient has a past history of blood transfusion in the past twice, and the patient was a chronic smoker and a tobacco chewer. Even here, the patient was vitally stable, pulse being 92 per minute, blood pressure 110 per 70 millimeters of mercury, RR 16, and saturation 99% on room air. ECG was suggestive of incomplete RBBB pattern. On local examination, here also the patient had redness, swelling, and increased warmth over the left leg extending to the mid-thigh level. The hemoglobin was 10.6, LDH was mildly raised 568, D dimer being mildly raised 1120, homocysteine increased, and the lower limb Doppler suggestive of acute thrombosis of the left femoral and the popliteal veins. CTPA, 2D echo being the normal limits, and flow cytometry CD55 59 negative. These are the ECGs in which first ECG is of the first patient in which complete RBBB with tachycardia is being seen. Second ECG, S1, Q3, T3 pattern, which was seen in the patient's ECG. This is just this is the photo of the CTPA in which massive pulmonary embolism extending into the main pulmonary trunk, lobar, and the segmental is being seen. So, yeah, coming to the results, 2 patients of PNH developed pulmonary embolism and deep vein thrombosis, out of which 1 patient was in cardiogenic shock secondary to massive pulmonary embolism and was thrombolized with streptokinase strip. 1 PNH patient presented with only DVT of the leg, and all the 3 patients survived and walked back home. Coming to the discussion part, paroxysmal nocturnal hemoglobinuria is a rare disease characterized by chronic intravascular hemolysis and an increased risk of thrombosis. The disease is caused by an acquired mutation of the X-linked PEGA in the hematopoietic stem cell. The PEGA gene product is essential for the correct assembly of the glycosyl phosphatidyl inositol anchors linking several proteins to the cell membrane. Therefore, this mutation results in a clone of blood cells deficient in GPI anchored proteins. Lack of the GPI anchored protein complement inhibitors CD55 and 59 on erythrocytes result in increased sensitivity to complement mediated lysis. CD55
time is over. Fast.
Yes, so CD55 inhibits C3 convertase, whereas CD55 inhibits the MAC. So thromboembolism is the most common cause of mortality, leading to approximately 40 to 67% of the deaths in PNH. 29 to 44% of the PNH have been reported at least one thromboembolic event during the course of the disease, and the rate of thrombosis in PNH is likely to be underestimated, which and the patients generally have a subclinical pulmonary thrombosis 6 to 10 patients. So it is requested for all the physicians to undergo a PNH workup if there is no obvious cause of thrombosis known in the patient. And these are my references, sir.
Okay, any questions from judges? Already time is over.
Yeah, the question is, you said the patient had cardiogenic shock.
Yes.
So is it cardiogenic shock or is it any other shock when the patient presents with massive pulmonary embolism?
Ma'am, I would like to go in the favor of cardiogenic shock because of the diastolic dysfunction, the right atrium, because of the back pressure. Whenever there is pulmonary embolism, there is extensive pressure, backward pressure in the right ventricle, because of which the diastolic filling is hampered and the stroke volume decreases in the patient.
Yeah, but it is what kind of shock? It is basically obstructive shock, isn't it?
Yes, ma'am, obstructive shock. Sorry, ma'am.
It's obstructive shock. Cardiogenic shock is basically reserved for those where the myocardium is dying, you know.
Yes, ma'am. Sorry, ma'am. It's an obstructive type of shock because
this
of
is
the
obstructive kind of shock. So the objection was on the classification, what you said. It's not cardiogenic shock, it is an obstructive shock.
Okay, ma'am. Obstructive shock. Sorry, ma'am.
Okay, the next person is Kevin Shah. Kevin Shah, are you ready with your presentation?
Yes, sir, I'm
Kevin
ready.
Shah?
Yes, sir, I'm ready with my presentation.
Let us go there. Let us go to the next one.
Good evening, panel. Is everyone able to see my screen? Hello.
Yeah.
Good evening. My name is Dr. Kevin. My presentation is on paraquat, fatal poisons. Introduction. Paraquat is a herbicide used widely throughout our country. The cost effectiveness and easy availability makes it more common use. Mild intoxication can cause minor gastrointestinal problems like vomiting, diarrhea, and orophageal ulcerations. With severe intoxication, there can be respiratory distress, pulmonary fibrosis, acute renal failure, and multi-organ dysfailure. Highest concentration of paraquat is found in the lungs. Unavailability of specific antidote, fatality remains very high in the patients of paraquat intoxication. Treatment modalities will include gastric lavage, intense diarrhea, diuresis, dialysis, and which can be used in the treatment of the same. The aim was to study the clinical outcome in the patients with paraquat poisoning. It's an observational case series study. All the patients who admitted in the paraquat poisoning were in the tertiary care hospital were included. Pregnant females were excluded from the study. Case 1, it's a 32-year-old male came with consumption of 10 ml of paraquat poison, was hospitalized within 4 hours of consumption. On admission, patient's pulse was 82, blood pressure was 120 by 18, saturation was 99. X-ray was within normal limits. Patient was given gastric lavage, antioxidants, and hemodialysis therapy. And there was a gradual increase in serum creatinine level, which rose to 4 milligram per DL on the day 4 of consumption. A CT KUB was suggestive of acute kidney injury. Patient was discharged on the 10th day of admission, and he did not have any respiratory admission during his course of illness. There was a second case, was a 35-year-old male with the consumption of about 15 ml of paraquat 6 hours prior to the admission, and the quantity was unknown. Patient was vitally stable on admission. However, on admission, X-ray was clear. The serum creatinine was 0.8. There was sudden increase in creatinine level on day 2. The dialysis was initiated, and however, the patient succumbed on the day 5th of the admission. There is this third case. A 24-year-old female came with history of suicidal consumption of 50 ml of paraquat within 66 hours of admission. The vitals were stable, normal with on admission, and X-ray showed bilateral haziness over bilateral lung fields, and it did not have any renal involvement throughout the course of hospital course. Her baseline creatinine was 1.1. Over the period of 24 hours, she went into ARDS, and she was taken a BiPAP for the same. Patient succumbed within 24 hours of the admission. This is the X-ray showing bilateral infiltration in the lower zones of the patient. There was this case for a 25-year-old male who came with consumption of 20 ml of paraquat within 8 hours of the hospitalization. On admission, patient's
हा पण
pulse
कुठे जायचं
vitals were normal.
हो
Creatinine
पण मग
was
मी जाऊ का
normal.
आम्हाला पण
Within 6 hours, the oxygen saturation dropped to 80%,
कुठं
and in next 4 hours, patient went into ARDS. So bilirubin raised from 1.1 to 5.5. The enzymes were within normal limits, and the patient succumbed
फर्स्ट फ्लोअरलाच का
within
फ्लोअर
28
कुठला
hours of the hospitalization. This case 5 is of a 24-year-old male who came with consumption of 2 ml of paraquat prior to the hospitalization with vitally normal, and he landed up into
काय टीचरचं नाव
AKI. Patient was given supportive treatment, and this patient was fortunately discharged after the 10 days. The sixth case is of a 24-year-old female who came with consumption of paraquat
ठीक है
about 40 ml 2 hours before the admission, and he had complaints of
हो हो
vomiting and breathlessness. Vitals were normal. However, the saturation was 80% on room air. Patient was intubated immediately in view of severe ARDS, and he died within 4 hours of the admission. This was the X-ray. And case 7 is of 28-year-old male who came with complaints of paraquat consumption about 2 ml 1 hour before the hospitalization. Vitals were normal on admission. The patient was given symptomatic treatment and monitored. He did not have any respiratory involvement during his course of the treatment, and patient's creatinine was gradually increased by day 6. However, fortunately, the patient was discharged with the symptomatic therapy. And this is the case 8 of an 18-year-old female with 9 months of pregnancy who came with complaints of paraquat compound consumption of around 15 ml about 8 hours before the admission. Vitals on admission were pulse was vitally stable. However, the saturation was 80%. The creatinine was an increasing trend, and by day 3, the creatinine reached 4.1. Patient was intubated in view of ARDS, and she succumbed by the day 4 of hospitalization. And this is case 9 of 18-year-old female with suicidal consumption of 20 ml of paraquat, and vitals were normal on admission. The creatinine was 0.9. However, within 6 hours, patient required NIV support, and creatinine raised from 1.1 to 4.6 within day 2. Hemodialysis was initiated, but patient succumbed within 28 hours. Results: out of 9 patients, 66% were male and 33 were female. The ratio was 2:1. The mean age of the patient was 30 years, youngest one 18, and the oldest was 60 years. The average length in hospital stay was 3.4 days, while the shortest was about 12 hours. The case fatality rate is 66%, and the mode of exposure to all the patients were oral. More the quantity of consumption, higher were the chances of the death were seen. In our patients, the patients who survived consumed less than 15 ml of paraquat poison. The main symptoms and signs of paraquat poisoning were nausea, vomiting, difficulty in swallowing, oral ulcers, breathlessness, and decreased urine output. It was seen that pulmonary involvement was seen in 55% of the patients. The saturation dropped from 6 to 12 hours, and patients were gradually intubated within 24 hours. With onset of pulmonary involvement, severe ARDS was seen within the shorter span of time, that is of 6 to 12 hours, and all the patients who had pulmonary involvement eventually succumbed. Renal involvement was seen in about 66%. The mean creatinine was 3.2. Among the patients with renal involvement, about 50% survived and 50% died. Hepatic involvement was seen in collaboration with the pulmonary involvement in one of the patients. So this is the summary of all the 9 patients.
The
Discussion.
time is over. Conclude
Yeah.
fast.
Okay.
Conclude fast.
Yes, sir. The paraquat is a herbicidal seen widely throughout the country. It gets rapidly absorbed from GI tract. Highest concentration is seen in lungs, followed by kidney, and lesser the quantity, lesser is better is the outcome. And the treatment, there is no antidote, and treatment is usually supportive. Okay, thank you.
Thank you. Any questions from judges? Okay, if there are no questions, we go to the next person, that is Saida Zaib Ara. Are you ready?
Yes, sir.
Okay, please share your screen and start the presentation.
So is my screen visible?
Yeah.
Oh. I'm going to present about clinico-etiological study of vaginal discharge in a woman at tertiary care hospital. Coming to introduction, symptomatic vaginal discharge due to vaginitis is the frequent complaint encountered every other day in gynecological and STI clinic. It accounts to 5 to 10 million OPDs per year all over the world. In India, among reproductive age, its prevalence is estimated to be 30%. Although it's not a cause of great mortality, but it can be a source of severe distress and several complications. Hence, an accurate diagnosis is recommended based on the knowledge of epidemiology of the genital tract infections, physical examination, consistent application of microbiological lab tests wherever needed. Small amount of discharge flows from the vagina daily as the body's way of maintenance of normal healthy environment. Normal vaginal discharge is usually clear with no malodor. Change in amount, color, odor, irritation, or any associated symptoms could be due to a change in a healthy bacteria of the vagina leading to vaginitis. Successful management of the symptomatic vaginal discharge lies in the diagnostic approach. In most of the situations, a presumptive diagnosis is based on the nature of the discharge, that is by clinical diagnosis, which is often incomplete, which leads to a mismanagement. Coming to materials and method, it's a 10 months prospective study done in a woman with a history of vaginal discharge. Using a structured questionnaire, detailed history of pertaining to vaginal discharge, its duration, color, consistency, odor, and any associated symptoms along with hygienic practices were noted. Past history of similar complaints and sexually transmitted infections were recorded. Clinical examination was done and vaginal discharge characteristics with 3 vaginal and high vaginal swabs were collected from posterior fornix and lateral of the vagina. Coming to materials and method, first swab was subjected to wet saline mount and seen under high power, that is 40x, to detect motile trophocytes of Trichomonas vaginalis along with yeast cells and clue cells. Second swab was used to determine pH, which test using 10% potassium hydroxide preparation and was seen under microscope for budding yeast cells. And third swab was subjected to gram stain to detect clue cells of bacterial vaginosis along with polymorphic nuclear cells with gram-negative intracellular bacilli. Diplococci. Coming to results, there were total 56 samples were collected from women with a history of vaginal discharge. Among them, vaginal infections were prevalent among 38%, that is 67.8% of the women. Among them, bacterial vaginosis was prevalent in 44% cases and were more common among multiparous women, followed by vulvovaginal candidiasis 31.5%, mixed vaginosis around 13%, gonococci 7.8%, and trichomonas vaginalis around 5.2%. The age-weight distribution of the study population is shown in the graph. Among them, 37.5 study population belongs to the age group of 26 to 34 years. These are the results. The gram stain showing clue cells emitted with the gram-positive rods. This is gram stain showing gram-positive budding yeast cells, and third one is wet mount with the flagellated Trichomonas vaginalis. Coming to distribution of different etiological agents, bacterial vaginosis is prevalent among 44.7, followed by Candida, that is 31.5. Next, mixed infection 13%. Gonococcal infection was prevalent in 7.8%, and Trichomonas lastly is 5.2% population. Then coming to results, prevalence of symptoms in women, that is vaginal discharge, as said, the total 56 samples. In that, homogeneous discharge was among 51%, curdled white discharge in 42%, and mucopurulent discharge in 5%. Associated with pruritus vulvae in 32% cases, dysuria in 26% cases, lower abdominal pain in 12.5% cases, and foul smelling discharge in 10% cases. Discussion, discharge per vagina is a common complaint among the women, can be physiological or pathological. The pathogens associated with it are bacteria, fungi, viruses, and protozoan parasite. The percentage of etiological agent varies with the geographical location, education and personal hygiene and economical status. Bacterial vaginosis accounts for approximately 1/3 of all the vulvovaginal infections. In the present study, the microbial diagnosis was made in 67% of the cases. All the women participated were married and most of them were multiparous women. In this study, the prevalence of bacterial vaginosis was 44.7%, followed by candidiasis 31%, and curdled discharge, which was associated with curdled discharge in 42% cases, pruritus 32% cases, followed by dysuria, with erythema and excoriation in the vulva was seen. Prevalence of mixed infections was around 13%. In this mixed infection, bacterial vaginosis with vulvovaginal candidiasis was around 3.5% cases, and bacterial vaginosis with Trichomonas vaginalis was 1.7%, where the gonococci was 7.8 and Trichomonas vaginalis was 5.2.
prevalent. In the present study, the 18% of the cases of the vaginal discharge were undiagnosed. This highlights the need of laboratory diagnosis of vaginal specimen before commencing the therapy. Coming to conclusion, bacterial vaginosis is most common cause of vaginal discharge, followed by candidiasis in my study. Simple tests like wet mount, Gram stain are useful tools for rapid diagnosis before starting an appropriate treatment. Hence, women with abnormal discharge visiting any healthcare facility should be properly examined, and microbiological studies necessary to overcome recurrent cases or reducing the therapy failure cost and injudicious use of antimicrobial agents. Also, reducing the risk of complications like PID, infertilities, preterms, low births, and abortions, and other increased risk of other STIs. Thank you.
Thank you, Saida, for finishing in time. Any question from judges?
No questions, but good presentation.
Thank you.
Yeah, and finished in time. Okay. So our next candidate is Rashmi Vanzari. Are you ready, Rashmi? Rashmi Vanzari? Are you there, Rashmi? Is Avi Tagi there? Avi Tagi?
Yes, sir. Yes, sir.
Who are you?
Rashmi.
Rashmi, are you ready with your presentation?
Yes, sir.
Please start.
Screen. I go. Right.
Share your screen. Okay.
Sir, am I audible?
Yes,
Sir,
you can start.
Sir, my topic, myself, Dr. Rashmi Vanzari. I am a junior resident from Ashwini Rural Medical College and Hospital. My topic is methotrexate overdose-induced pancytopenia and mucocutaneous ulceration. Introduction. Methotrexate is a well-known anti-cancer and disease-modifying anti-rheumatic drug actively used in the treatment of wide spectrum of human alignment, including cancer, rheumatoid arthritis, psoriasis, asthma, primary biliary cirrhosis, and is also an immunosuppressant. Methotrexate is a folate antagonist used in the treatment of various malignancies, autoimmune disorders, and abortion. It is transported into the cell by active cellular uptake and an active flux transporter. Once in the cells, the methotrexate inhibits dihydrofolate reductase, an enzyme responsible for the conversion of dihydrofolate to tetrahydrofolate. Consequently, there is a reduction in the thymidylase and purine biosynthesis, and DNA synthesis is eventually halts, and the cells cannot longer replicate. However, several studies have demonstrated the adverse effect of methotrexate in a long-term or high-dose treatment. One of the major concerns being is pro-oxidant and non-specific action. Frequently observed adverse events of methotrexate include nausea, vomiting, diarrhea, elevated transaminase, pulmonary and hematological toxicity as rare. In methotrexate untreated rheumatoid patient, the prevalence of hematological toxicity including leukopenia, thrombocytopenia, megaloblastic anemia, and pancytopenia is estimated to be around 3%. Pancytopenia has been reported in around 1.0 to 1.4% of cases. Methotrexate-induced pancytopenia is potentially fatal complication and associated with significant mortality. The reported mortality varies from 17 to 44%. We previously reported 5 cases of methotrexate-induced pancytopenia. The risk factor in those patients were hypoalbuminemia and lack of folate supplementation and dosing errors. One patient died due to the severe pancytopenia. The exact frequency, risk factors, and mechanism implicated in methotrexate-induced pancytopenia are unknown. Methods. 25 patients with methotrexate-induced pancytopenia were identified by a Department of Medicine in Ashwini Rural Medical College and Hospital, reviewed by pharmacy records and personal communication. Aim of the study was the severity of pancytopenia dependent on case of dose and duration of methotrexate. Source data. The study was conducted in Internal Medicine Department of Ashwini Rural Medical College and Hospital, Solapur. Pancytopenia, in which the pancytopenia was defined as a WBC count less than 3,500 hemoglobin, 11 gram per deciliter, and platelet count was 130,000. In case of severe pancytopenia was defined as a WBC count was less than 2,000, and hemoglobin was 10 gram per deciliter, and platelet count was less than 50,000. Patient notes were reviewed, and the following data recorded as a age, sex, indication for methotrexate, median dose, and duration of treatment. Study used the substantial number of patients are treated with methotrexate for the other inflammatory condition. Therefore, the prevalence of methotrexate induced pancytopenia in this cohort study is estimated. This is the study. This is a study table of non-severe pancytopenia versus severe pancytopenia, in which we took 25 cases, of which 15 were conducted as a non-severe pancytopenia, and 10 were was a severe pancytopenia, in which the data outlined 10 had seen severe pancytopenia, 15% patient died, 4 were taking folic acid. Of the 15 non-severe pancytopenia, 8 were taking folic acid. The 9 patients who were detected by blood monitoring compromised. Compromised 8 with non-severe, 1 severe pans, all recorded except 1 who died of acute myeloid leukemia. 18 were hospitalized, 9 required blood transfusion, 17 folic acid rescue, and the remaining 8 daily folic acid. The mortality was 28%. Death were due to sepsis in the 5 that acute myeloid leukemia. Non-parametric testing showed no significant difference between the groups, either by dose or by duration of treatment. However, when they're comparing those who recovered from severe or non-severe pancytopenia, the former were taking the significantly higher dose than the latter. Although the duration of the treatment may be the risk factor in the development of severe pancytopenia, this was not statistically significant. Result: the median age was 76 years, interquartile range 13 out of 17 female and 8 was male. The indication for methotrexate was rheumatoid arthritis, Wegener's granulomatosis, psoriatic arthritis, and the giant cell arthritis. Pancytopenia was detected in 9 by routine blood monitoring according to the standard British Society of Rheumatology guideline. 7 presented with blooding that gums, urinary tract, epistaxis, vaginal and rectal. Oral mucositis was documented in 10 at presentation. 7 had severe pancytopenia. 1 presented with an acute coronary syndrome secondary to anemia. Concurrent sepsis was identified in 9 and 5 subsequently died. The conclusion was my study was it is the utmost importance that the primary care of physician of this complication and recommendation, because the majority of the series of complication can be detected on time and even prevented. Patient on methotrexate therapy should be regularly monitored with liver function test and CBC to identify myelosuppression and avoid the sequel of pancytopenia. Renal function must also be monitored, as these drugs uses mainly the kidney for excretion. These are my references. Thank you.
Okay, thank you. Any questions from judges?
Go ahead.
Okay, if there are no questions, we go to the next candidate, that is Avi Tyagi. Avi Tyagi, are you ready?
Good evening, sir. I'm ready, sir. Good evening, panel.
Please start your presentation.
Yes, sir. Good evening, panel. I shall be presenting a study of association of autonomic function using heart rate variability with the dyslipidemic status among male adults. It is a cross-sectional analytical study. I shall cover it in the following under the following topics: from introduction, followed by aim, material and methods, results, discussion, conclusion, and references. To introduce, we all know that lipid metabolism is central to the normal physiology, and it is very important in understanding the pathogenesis of any cardiovascular disease. And these cardiovascular diseases, the major worldwide cause of morbidity and mortality has been found out to be dyslipidemia. And it is characterized by elevated levels of cholesterol, triglycerides, and/or lipoproteins in the blood. Lipid disorders are usually detected by fasting blood lipid profile analysis if the low density lipoprotein levels are more than 130 milligram per dl and high density lipoprotein levels are less than 40 milligram per dl on 2 different occasions. It is also associated with an increased risk of cardiovascular disease by the fact that an increase in plasma concentration of cholesterol in certain lipoprotein fractions can result in the increased deposition and retention of cholesterol in the vascular walls, which leads to atherosclerosis and contributes to the development of autonomic imbalance, which ultimately causes cardiovascular disease. Cardiovascular diseases, cardiovascular disorders are leading causes of death among the adults in the world, and people with hyperlipidemia are roughly at twice the risk of developing cardiovascular disease. Now, these cardiovascular diseases, as we are talking about dyslipidemia, also have seen that there is autonomic dysfunction in form of sympathetic and parasympathetic imbalances. It may lead to hemodynamic and metabolic attenuations that increase the risk of any development of cardiovascular disorder. Now, heart rate variability, it measures the effects of the autonomic function on the heart alone. It is a simple and non-invasive tool to evaluate the autonomic function of the cardiovascular disease. Even regulation of the heart can change the heart rate and the rhythm. This heart rate variability can record the beat-to-beat variation during a normal ECG record. The aim and objectives of the study are as follows. We aimed to study the association of autonomic function using heart rate variability with the dyslipidemic status among the male adults. The objective was to determine the resting heart rate variability in dyslipidemic and normal lipid profile Indian males. The materials and method, it was a cross-sectional analytical study. The study population comprised of 20 newly diagnosed male patients of dyslipidemia. It took place in the exercise lab of a tertiary care center. We did the study over 2 years. We included newly diagnosed dyslipidemic males in the age group of 18 to 60 years. Any cardiovascular disorder like hypertension, ischemic heart disease, valvular heart disease, any past history of diseases which could affect the autonomic function like diabetes mellitus, congenital heart disease, etc., were excluded from the study group. The subjects were allocated to the study group and the control group based on their lipid profiles. The subjects were then explained about the methodology, and informed consent was acquired in a written form. The subjects were then asked to report to our exercise lab between 8 a.m. and 10 a.m. for the cardiac autonomic function test. The subjects were instructed to avoid any tea, coffee for the past 12 hours before the test. They were told to refrain from medications which could influence the cardiovascular system, such as anticholinergics, antihistaminics, cold, cough medications. Also, in case of any adversity of the health, such as any poor overnight sleep or any fever or body pain, the test would have to be postponed. The subjects were also advised to come with a free and evacuated bowel and emptying of bladder. Before we started doing the HRV record, 5 ml of fasting blood was collected for the lipid profiling. For the anthropometric measurements, height was taken using a stadiometer, weight was taken using a scale. The short-term heart rate variability was then recorded. The recorded 5-minute ECG was again filtered with a bandpass filter, and then the threshold algorithm of LabChart Pro software was utilized to select the RR interval. Later, these RR tachograms were analyzed using the Kubios 2.0 software, and the data was then analyzed and the results were obtained. The results that we obtained in the study have been tabulated. As we can see, the LF-HF ratio, which determines the sympatho-radial balance, is showing a significant difference between both the groups. There is a lower LH-HF ratio, which reflects the parasympathetic dominance. And in our study, LH by FH ratio in the normal lipid profile group is found to be significantly lower than those of the hyperlipidemic group. The total power also in the dyslipidemic group is lower than the normal. Despite the limitations, we have found that the resting heart variability gets impaired with dyslipidemia, and it is also it can also lead to cardiac risk and a poor prognosis. However, further research is definitely required to find out the actual cutoff limits for the resting HRV in consideration with dyslipidemia or hyperlipidemia. Thank you. These are my references. I end the presentation with the same.
Thank you, Avi, for finishing in time. Any questions?
So what do you think are clinical implications of the study?
Sir, the clinical implications when we speak of the same, like traditionally the autonomic nervous system cannot be actually directly checked. So this, while by using this easy and which is non-invasive, this investigation, we can easily direct the patient towards a particular treatment profile in case he is developing or going towards an autonomic dysfunction, which is caused by the dyslipidemia or the inflammation or the other underlying factors.
Okay, thank you. The next person is Sanskriti Naikade. Are you ready, Sanskriti?
Yes, sir. I'll just share my screen.
Please start, yeah.
Yes.
Please carry on.
Am I audible?
Yes, carry on.
Can my screen be seen?
Yeah, please carry on.
Yes, I am Dr. Sanskriti Naikade from junior resident from the Department of OBGY from Ashwini Rural Medical College. My today's topic of presentation is the clinical study on ectopic pregnancy at Rural Tertiary Care Center. Ectopic pregnancy is a life-threatening condition that every practicing obstetrician and gynecologist encounter his or her practice. It greatly endangers the life of a woman and also the future fertility by causing damage to the fallopian tube and or the ovary. The physician who is ectopic minded rarely fails to make the diagnosis. The word ectopic is from Greek word ecto and topos, which means out of place. An ectopic pregnancy occurs when the developing blastocyst implants either outside the uterus, that is in the fallopian tube, or any abnormal position within the uterus, cornual, and cervical region. The aims and objectives are to study the age group, parity, and risk factor with respect to ectopic pregnancy, to study the clinical presentation and intervention required in the ectopic pregnancy. The study area was Ashwini Rural Medical College Research Center in Solapur. The duration was of 1 year, and it was done a retrospective observational study. The inclusion criteria were all the women with confirmed ectopic pregnancies. The investigation and admission were done, routine investigations, ultrasonography, urine pregnancy test, serum beta HCG was inconclusive. The following parameters were studied: age, parity, results of urine pregnancy test, period of amenorrhea, clinical features, risk factors, site of rupture, incidence of ruptured and unruptured ectopic, the type of surgery performed. So these were my results. Out of total 20 patients which were studied, 95% of the patients were ruptured ectopic and only 5% patients were unruptured ectopic. Out of these, the age group which belongs to the ruptured ectopic pregnancy was 25 to 29 years of age, followed by mostly were seen was gravida 2. Most of the patients who came to our casualty showed the complaints of amenorrhea, followed by abdominal pain and vaginal bleeding, which is the classical triad for ectopic pregnancy. Most common site of the rupture in ectopic pregnancy were ampulla of the fallopian tube. Of all these patients came to casualty, all were UPT tested positive. The risk factors were studied were previous DNC, history of PID or tuberculosis, intake of ovulation induction drug, that is assisted reproductive technology, previous ectopic pregnancies, history of tubal ligation or idiopathic. Out of this, most of the patients came with the history of previous ectopic pregnancy. Type of surgery for ruptured ectopic pregnancy, majority of them were managed by salpingectomy, and out of these, 4 were done for laparoscopic salpingectomy. Discussion. Although the early diagnostic tools were available, we had to manage most of our patients as surgical emergency with established diagnosis of ruptured ectopic pregnancy. According to Rajendra, incidence of tubal ectopic was 96.20% and most common site was ampulla. Salpingectomy was done in 65% cases, whereas our study also showed ampulla was the most common site and salpingectomy done in 80% cases. According to Mamta, tubectomy was the most common risk factor, whereas our study previous ectopy was the most common. Our study also showed that 35% were presented with shock, which was in accordance with the study by Mamta. Study by Prem Singh Tak found that 79.48% cases of ruptured ectopic and 11.53% of unruptured. Our study also found that 95% cases of ruptured and 5% cases of unruptured ectopic pregnancy. So the conclusion is, ectopic pregnancy is a nightmare for all the obstetricians. Physicians should be sensitive to the fact that in the reproductive age group, any woman presenting with pain in the lower abdomen, diagnosis of ectopic pregnancy should be entertained irrespective of the presence or absence of amenorrhea, whether or not she has to undergo sterilization. One should be always ectopic minded for patients presenting with classical triad of amenorrhea, pain in abdomen, and pervaginal bleeding. Early diagnosis, resuscitation, and prompt intervention will reduce the maternal morbidity and mortality. These are my references. Thank you.
Thank you, Sanskruti, for finishing in time. Any question from judges?
What was the presentation of unruptured ectopics? 5%.
Came with amenorrhea and pain in abdomen.
Amenorrhea and pain in abdomen. Okay. That's good.
Okay, why do you think you had 95% of patients presenting with rupture?
Majority of it becomes, even in like our hospital is set up in rural society, majority of the cases have been ignored, like amenorrhea, pain in abdomen. It is common sometimes in the early trimesters of pregnancy. Unless and until it shows like PV bleeding or symptoms of shock, people then land up into the casualty.
But still, out of total ectopics, 95% coming with rupture is something which is not very common occurrence. There is something amiss. Which kind of bias this you can call? If I have to be more directed one.
Randomized.
What kind of bias is there in the study?
Double tire bias.
No. Okay, this is a referral bias because most of the patients have been referred to you after rupture. That is why you are getting such high number of patients coming with rupture. Those who have had actually unruptured ectopics possibly have been tackled, and once they have ended up having rupture, they have been referred to you. So this is classically happens when you find some finding which is not usually or which is not fitting into the usual numbers reported in other studies. If you get it in excess number, you have to try and find what is the reason for that, and this classically is a referral bias.
Okay. Thank you.
Okay, thank you, Sanskruti. The next person is Rutvik Arve. Are you ready, Rutvik?
Yes, I'm ready. I'm Dr. Rutvik Arve, going to present from the Harshad Jain because of a network issue. I'm audible?
That's fine. Carry on. Yeah, carry on.
Just a minute.
Share your presentation. Yeah.
Good evening to all of you. I'm Dr. Rutvik Arve, medicine resident from the Ashwini Rural Medical College, Kumbhari. My today's presentation topic is a study of lipid prophylactics. Introduction. Precursor state to the diabetes mellitus is called as a diabetes are absent, but the blood sugar is borderline high. Type 2 diabetes mellitus is difficult as mostly
You're not audible.
Hello, am I audible?
You are audible now.
Yes, audible am.
Yes, you are audible.
You are audible, but your screen is not seen.
Is it seen?
No.
Rutvik, you are audible, but the screen is not seen.
Just a minute.
Can you just set up your presentation so that we can come back to you after we get we are done with the next one?
Okay.
Dr. Harshad Jain, you mute yourself, please.
नाही हर्षदच वापरतो तो.
पण मग म्यूट करू दे ना, पुढचा घेतोय ना.
Okay.
So Aishwarya Subhash Jadhav.
Yeah. Aishwarya Jadhav, are you ready? Aishwarya. That's fine. Aishwarya, you can continue.
So can you see my screen?
Yes, we can see.
Yeah, please carry on.
Good evening, everyone. I am Dr. Aishwarya Jadhav from Ashwini Rural Medical College, Solapur. My topic is prevalence of insulin resistance by homeostatic model assessment in patients of polycystic syndrome. Polycystic ovarian syndrome is one of the most common endocrine disorder of reproductive age group and affects approximately 6 to 16% of the general population. This disorder is characterized by androgen excess and oligoovulation or anovulation after the exclusion of other related disorders. In addition, presence insulin resistance accompanied by compensatory hyperinsulinemia. PCOS remains one of the important causes of anovulatory infertility, and insulin resistance adds to the problem of ovulation induction in these patients. The American Diabetes Association recommends initial DM screening and then periodic testing in obese or overweight women and adolescents diagnosed with PCOS. Overall insulin resistance and the compensatory hyperinsulinemia affects some 55 to 70% of women with PCOS. Considering high incidence, that is 20 to 80% of insulin resistance in obese patients, there is 20 to 25% of population found to have insulin resistance in spite of disease. So while considering optimization of patients with PCOS, it is worth proving insulin resistance irrespective of the disease. Amongst different tests to diagnose insulin resistance, the homeostatic model assessment of insulin resistance has been proved to be useful as a an index used to determine if insulin resistance is present in a patient or not. Now, HOMA-IR calculator is also available online, and on entering patients' fasting glucose and insulin values, it directly gives us the value of HOMA-IR. The formula for HOMA-IR is, we see the fasting insulin into fasting glucose, which is divided by 405, where insulin is in milli international units per liter and glucose in mg per dl. In general, the cutoff value is 2. Any result above this suggests insulin resistance. Now, HOMA-IR index is simple to use and requires such little data. It is used widely because of its simplicity and non-invasive nature. Now, the aims of the study is to determine the prevalence of insulin resistance in patients with PCOS, and objectives are to study the pattern of BMI according to the WHO criteria in patients of PCOS, and to study the prevalence of insulin resistance in each BMI group, and to assess the need for HOMA-IR test in patients of PCOS with normal BMI. Now, the study area was Ashwini Rural Medical College, Hospital and Research Center, Solapur. The duration of study was of 4 months, from April 2022 to July 2022. It was a retrospective observational study, and the inclusion criteria consisted of all patients diagnosed with PCOS, which was selected from the Gynac OPD. Now, the following parameters were studied, that is the BMI, fasting glucose, fasting insulin, and HOMA-IR testing was done. Now, we distributed these cases according to their BMI. We studied total 18 patients, and in our study, 33.3% cases were observed having normal weight and 33.3% cases were overweight. 22.2% cases were underweight. Obesity was observed in 11.11% cases according to their BMI. Then we studied the prevalence of insulin resistance by HOMA-IR test in each BMI group. There was no prevalence of HOMA-IR in underweight cases. Out of normal weight cases, 83.3% cases were observed with insulin resistance. 100% cases were observed having insulin resistance in overweight cases and cases with obesity respectively. Now, in our study, there was statistically significant correlation was observed between the BMI and HOMA-IR measurements, which we can see in this graph. So in our study, the insulin resistance appears to be independent of obesity and is also present in patients with normal BMI. According to a study conducted by Catherine Marin, prevalence of insulin resistance in PCOS patients by HOMA-IR was 64%, whereas in our study, the prevalence of insulin resistance was approximately 72.2%. According to John Marshall, all patients with PCOS, irrespective of their BMI, should be treated for insulin resistance. Our study is indicated towards treatment of patients within normal BMI range with raised HOMA-IR levels. The hyperinsulinemia appears to be an important factor in maintaining hyperandrogenemia, which induces excess androgen production by the theca cells and also a co-gonadotroping effect, causing increase in LH stimulus seen in a majority of women with PCOS. So for conclusion, in patients with PCOS, the prevalence of IR was approximately 72% according to the HOMA-IR measurement. A majority of women with PCOS have insulin resistance and consequent hyperinsulinemia. The latter commonly leads to hyperandrogenemia with negative effect by lifestyle changes or metformin, leads to improvement in reproductive and metabolic abnormalities and reduces future development of diabetes and arterial disease. Along with lifestyle modification with exercise and dietary advice, administration of metformin can be useful in overweight and obese patients. Normal BMI patients who prove to have insulin resistance with raised HOMA-IR test may also benefit from medical therapy. Thank you.
Okay. Thank you, Aishwarya. Any questions from judges? Thank you for finishing in time.
Basically, you wanted to look at what is the prevalence of insulin resistance in patients with PCOD.
Yes, sir.
And this is to the tune of 70%.
Yes, sir. So basically, we wanted to see how many patients of PCOS have insulin resistance. So some people, usually all PCOS patients are being treated with metformin. We don't usually need to do that. Or some doctors even go for providing with administration of metformin with obese and overweight patients. So what we are going towards is measure their insulin resistance by HOMA testing
and then give metformin.
Again, so the prevalence, so you're proposing that check insulin resistance and then use metformin. Don't go blindly for metformin.
Yes, yes, sir. Yes, sir.
Is the study powered enough to make such conclusion?
Yes, sir. It is even advised in UK.
No, it's okay. But what is the power of this study? What is the sample size of our
Sample
study?
size.
The sample size is 18 patients were studied.
So can we make a recommendation based on 18 patients? Any clinical recommendation? The study is very small. At the best, it can be a hypothesis generating study. It cannot dictate the clinical practice.
So what all of you should refrain from doing is just present the conclusion of your study instead of giving further recommendations. You should just conclude at that we have found out this.
Okay.
So this is common mistake which happens when we are trying to answer a research question. We try to mix the clinical practice into it. If you start mixing the clinical practice into research question, it gets biased, significant bias. So you need to be more objective when you are actually presenting a research paper or article.
Okay.
Okay. Thank you, Aishwarya. Is Rutvik, are we ready?
Yes, yes, ready, sir.
So you can start your presentation, Rutvik.
Okay, sir. I'm Dr. Rutvik Arve. I'm going to present the topic on study of a lipid profile in a
Hello.
Hello. I am audible? Yes, yes. Please carry on. Study of a lipid profile in a pre-diabetic patient. Introduction. The precursor state to the diabetes mellitus is called as a prediabetes, in which all symptoms of a diabetes are absent, but the blood sugar is borderlinely high. Early diagnosis of a type 2 diabetes is difficult as mostly it is asymptomatic and present with a complication. About half of the diabetes in the world are not diagnosed according to the recent studies. The pre-diabetic individual have a higher risk of a progression to the diabetes in the future. American Diabetic Association has defined the pre-diabetes as an impaired fasting glucose when the fasting plasma glucose level is from 100 to 125 milligram per deciliter, and the impaired glucose tolerance when the plasma glucose level after 2 hours and oral glucose tolerance test is from 140 to 199 milligram per deciliter. Pre-diabetic screening can stop the early progression to the diabetes and also prevent the complication. Aims and objective of my paper is aims to study the prevalence of a dyslipidemia in the pre-diabetic patient. Objectives are to analyze the lipid profile in a healthy population for the reference value, to analyze the differences in the lipid profile of a pre-diabetic. Maternal method, a hospital-based cross-sectional case control study was conducted in 178 subjects to evaluate the role of a lipid profile in pre-diabetic. Study was carried out in the following 2 groups of 89 subjects in each group. Group 1 is a healthy participant between the 20 to 70 years of both genders, not suffering from the diabetes and acute chronic ailments, not any medication which could influence the lipid profile. Group 2 are the men and women aged of 20 to 70 years of years having established diagnosis of prediabetes. Study design, a hospital-based cross-sectional study, cross-sectional case control study is my study design. Study center is a tertiary care center, Arch Kumbhari. Inclusion criteria are patient more than 18 years with the pre-diabetic status according to the ADA criteria, fasting blood sugar level in between the 100 to 125 milligram per deciliter, the 2-hour postprandial glucose after the 70 gram oral glucose standards 140 milligram to 199 milligram per deciliter, HbA1c 5.7 to 6.4, patient who are willing to give a written consent. Group 1 are the healthy participants are the controls. Exclusion criteria are type 1 and type 2 diabetes patient with the active autoimmune disease, malignancy, hypothyroidism, SLE, and the patient who are on glucocorticoid. The appropriate statistical software is used for the statistical analysis. These are the graphical representations according to the age, gender, blood glucose level, and glycosylated hemoglobin. In group in group 1, the fasting glucose level is lesser as compared to the group 2. In group the HbA1c level in a group 1 is 5.27 and in group 2 is 6.14, which is more in a group 2. These are the comparison of a lipid profile parameter in a subject which includes the total cholesterol, triglyceride, HDL, VLDL, triglyceride HDL ratio, and LDL HDL ratio. Moving towards the discussion, the hospital-based cross-sectional study was done, which gives the result of the fasting and postprandial value of a subjects in the group 1 is significantly lesser as compared to the group 2. It was observed that also glycosylated hemoglobin of a group 1 were significantly lesser as compared to the group 2. The mean cholesterol value of a group 1 is lower than the group 2. The triglyceride, LDL, VLDL values of a group 1 is lower than the group 2. The mean HDL value of a female group 1 was significantly higher than the female patient of a group 2. The VLDL value of a group 1 was significantly lower than the group 2. The conclusion of my paper is lipid profile in the pre-diabetic subject containing a total cholesterol, triglyceride, and triglyceride HDL ratio and LDL HDL ratio are remarkably raised as compared to the normal healthy subject, and HDL cholesterol is lower than the normal subject. Lipid profile is in a pre-diabetic subject was deranged compared to the normal healthy subjects. The individual are high risk of a development of a cardiovascular diseases. Control of a lipid by lifestyle modification and pharmacological therapy can prevent the cardiovascular complication. Study of lipid profile in pre-diabetic for screening of a dyslipidemia is helpful for the early prevention of a cardiovascular complication. These are the references for my paper presentation. Thank you.
Thank you, Rutvik. Actually, I can ask one question because you have finished in time. When do you start pharmacological therapy? What is the therapy?
Indication of a pharmacological therapy, the patient who have a deranged lipid values, like more cholesterol level, more than the around 200, which the consider for the, and the other lipid values, low, more LDL value.
So all patients who have abnormal lipid profile, you start pharmacological therapy. That is correct?
No, sir. Which having the in a pre-diabetic state.
Okay. Sorry. Questions from judges, please. Your questions.
Actually, the conclusions which you have given, the data is not there for that. Like you commented on treatment, but the data is not there.
No, I'm just adding the treatment parts, ma'am. It's not on the.
That should not be added because you have not studied it. So in the conclusion, actually, you have no right to add that as a conclusion because you haven't worked on it, isn't it?
Yes, yes.
Or at least there should be some evidence to that can be said. But before starting study, what was your expectation? Are the results according to your expectation or they are contrary to your expectation?
I'm not expecting the lipid values are that much increased, but the result was showing the lipid values increased, because in pre-diabetic the value are 100 to just 125 for the fasting, and for postprandial is just a borderline. So we are not expecting the that much increase in the lipid profile.
Okay, fine. Coming to there's a different analogy. The patients with oral cancer at an increased risk of lung cancer.
Yes.
This is something which is anticipation. Based on what? Why do we anticipate this?
Co-founder as a co-founders.
Confounders, not confounders. They share a common risk factor.
Yes, yes.
So smoking or tobacco is a common risk factor for both. So similarly, for pre-diabetes as well as for dyslipidemia, there is a common risk factor. And you anticipate that they are likely to have higher proportion of dyslipidemia as compared to the non-diabetic or healthy populations or healthy controls. in your study. So you have not included healthy controls, or you have included healthy controls?
Yes, included the healthy controls.
Okay. So the results are according to expectation. This is because they share a common risk factor. Okay, fine. Thank you.
Okay, thank you, Rutvik. The next candidate is Almelu Varsha. Are you ready?
Sir,
Almelu.
yes, sir. Can you hear, sir?
Almelu Varsha.
You're mute now. You can unmute and start.
Please
Now,
unmute yourself.
Can you hear, sir?
Yeah.
Yes.
Yes. Please carry on. Share your screen.
Good evening, everyone. I like to present on my topic of effect of placental cord drainage on the third stage of labor. Introduction.
Your presentation is not visible.
Sir, now, sir.
It's coming. It will come. We'll have to wait for some time. Yes, it is visible now.
Visible. Good evening, everyone. I like to present on my topic of effect of placental cord drainage on the third stage of labor. Introduction. The third stage of labor is defined as the period of the birth of the baby to the expulsion of the placenta. The postpartum hemorrhage is the most common complication that occurs in the third stage. The placental cord drainage has been suggested as the way of minimizing the impact of cord clamping on the third stage of labor for the mothers. Placental cord drainage is defined as the unclamping the umbilical cord on the maternal side, thereby permitting the blood from the placenta to drain freely into a vessel immediately after the clamping and cutting of the umbilical cord. It is physiologically possible that the draining blood from the placenta would reduce its bulkiness and allowing the uterus to contract and retract effectively, leading to the delivery of the placenta, and may reduce the duration and the amount of blood loss on the third stage of labor. My main aim is mainly to observe the effect of placental cord drainage on the third stage of labor. My objectives are mainly to compare the amount of blood loss in both group 1 and group 2, and to compare the time duration taken for the separation of placenta in the third stage of labor in both groups. It was an observational study which has been conducted in Bharati Medical College from June 2021 to November 2021, and participants who voluntarily agreed to involve in the study has been involved, and a written consent of all participants has been taken. Low risk pregnancy women will be taken as the participants. The study was carried out after the approval of the Institutional Ethical Committee. My inclusion criteria were: it was a singleton pregnancy, term pregnancy of a gestation age 37 to 41 weeks, vertex presentation, viable fetus, estimated fetal weight by ultrasound of about 2 kg to 3.5 kg, spontaneous vaginal delivery, and participants who are voluntarily agreed to participate in the study. And my exclusion criteria are: the participants whose hemoglobin is less than 8 gram per deciliter and parity more than 4, over-distended uterus which is seen in polyhydramnios, multiple pregnancy and large baby, if any obstetric and medical complications like antepartum hemorrhage, hypertensive disorder, gestation diabetes mellitus, premature rupture of membrane, and coagulation disorders. Any history of any previous surgeries on the uterus, instrumental delivery, fetal compression, and uterine malformation. My study population, I have taken 60 participants, in which group 1 30 participants and group 2 30 participants. In group 1, the maternal side of umbilical cord will be unclamped immediately after it was cut and left open to drain the blood in a vessel until the flow ceases. In group 2, the maternal side of umbilical cord will be remained clamped. In group 1, if bleeding doesn't cease minutes unclamping the umbilical cord, then we reclamp the maternal side of umbilical cord, and these participants were not involved in this study. The participants were selected alternatively in group 1 and group 2. The duration of the time taken, a stop clock was used to calculate the duration of the time taken during the third stage of labor. The amount of the blood loss was measured by using with the help of an absorbable molly sheet, mopping pad, and vaginal pad. The weight of all blood-soaked material and cloths used to determine the cumulative volume, that is 1 gram weight is equals to 1 milliliter blood loss. The blood loss of blood-soaked item has been calculated in the following way. Wet item gram weight minus dry item gram weight, that is milliliters of the blood within the item. The weighing machine was used to measure the placental weight. These are the instruments which are used to calculate the amount of blood loss and weighing machine. My data collection was demographic and case record was checked to rule out the high risk pregnancy, pre-delivery pulse rate, blood pressure and hemoglobin noted, per vaginal findings and progress of labor. The results were given in the mean, median and standard deviation. All measurements were compared using a chi-square test, considering the p-value less than 0.05 to be statistically significant. In group 1, I have compared duration of the third stage of labor in both group 1 and group 2. In group 1, among 30, 22 were coming under the category of 6 minutes to 8 minutes 59 seconds, and 8 are coming under the category of 3 minutes to 5 minutes and 59 seconds, in which mean is 6.5, p-value 0.37. In group 2, among 30, 20 are coming under the category of 12 minutes to 14 minutes 59 seconds, and 10 are coming under the category of 9 minutes to 11 minutes 59 seconds, and the mean is 12.5 and p-value 0.19. In table 2, I have compared the amount of the blood loss in both group 1 and group 2. Among 30 in group 1, 24 are coming under the category of 151 to 250 ml, and 6 are coming under the category of 50 to 150 ml. Mean is 191.53, p-value is less than 0.05. In group 2, among 30, 18 are coming under category of 351 to 450 ml. 12 are coming under the category of 251 to 350 ml. Mean is 359.63 and 0.30. Placental weight was compared in both the groups. In group, all the participants are coming under category of 200 to 300 grams, and mean is 253.66. In group 2, 22 were coming under the category of 401 to 500, and among 38 are coming under category of 301 to 400, mean is 420.53. In my study, there were no cases of retained placenta in both groups. All the participants were monitored for 24 hours to identify the postpartum hemorrhage. In our study, 0% in group 1 and 3.33 in group 2. This study was, the present study finding is supported by the study by the Ramska in 1999. He first reported that the duration of the third stage labor was significantly shorter when using the placental cord drainage method. A study was also done by the F. Dickinson I. Simon in 2005. The results showed that the cord drainage reduced the length of the duration of the third stage labor. The mean difference was about 2.85 minutes. Jayacyclone et al. Reported that the mean value was 8 minutes in group 1 and 15 minutes in group 2. Cochrane systemic review concluded that the cord drainage result in statistically reduction in the length of the third stage of labor.
The time is over. Conclude.
Based on the study, it has been concluded that the drainage of the umbilical cord in third stage of labor effect on the outcome of placental drainage, like reduction in the duration and the amount of blood loss. Placental cord drainage is a simple, safe and non-invasive method of great use in day-to-day obstetric practice, that it does not require the extra efforts and cost or equipment. My limitations are amount of blood loss was not measured accurately. Sample size is small, so generalization is not possible. Blood loss is common during third stage of labor. These are the references. Thank you.
Thank you, Almelu. Any question from judges?
Has it become the usual practice or standard of care to practice unclamping of the cord?
Sir, actually, in third stage of labor, we used to clamp only, sir. We doesn't unclamp. But when we try this new, some other institute, they are practicing, sir. When we are doing it, the amount and duration is less, sir. So
the Cochrane has Cochrane review of the studies, large data, more than 10,000 odd, has suggested it does improves the outcome. Why has it not yet become the standard of care? Are there any barriers?
Sir, actually, yet more studies has to become, sir. Whether it can be because the group population which study has been done in small groups, sir. So
Cochrane will not conduct a review if the number of participants is small. If there has been a Cochrane review, that means the number of participants in the studies has been significant. Yes. Or the problem was clinically significant, which begged for the answers. And if they have given positive, usually the Cochrane doesn't come with positive recommendations. Usually they come with negative recommendations after analyzing all the data and looking at the quality of studies. Since your case, the Cochrane has given a positive recommendation, my logical question is, has it become the standard of practice?
Actually, in here in our college, we are practicing now, sir, but it doesn't come with the recommendation of active management of third stage labor, sir. But some of the doctors are practicing, sir, which thing, but it doesn't come under the recommendations.
Fine. Thank you.
Thank you, sir.
Okay, thank you, Almelu. The next person is Akash Gangane. Akash, are you ready?
Yes, sir.
Please start your presentation, share your screen.
Hello.
Yeah,
can you
carry
please
on.
stop the Varsha, can you please stop the sharing of the screen? I'm not able to share.
Varsha, please stop sharing your screen. Varsha?
Sir, I will leave, sir.
Please stop sharing your screen.
Yes. Is it stopped, sir?
What is this? No.
Fine.
Yeah. Are my slides visible, sir?
Yes, carry on.
Yes. Today I'm presenting a case series for our first paper presentation. Acute intracerebral bleeding in a patient of COVID-19, a rare complication of COVID-19. Coming to the background, COVID-19, apart from a commonly involving respiratory system, also involves central nervous system with a clinical presentation ranging from headache to the ischemic stroke and intracerebral or intraparenchymal hemorrhages. Thrombotic episodes are more common than the hemorrhagic ones, but they should not be ignored. Hemorrhagic presentation with COVID-19 are rare but serious complications. Some case reports have been published so far about the hemorrhages in the cerebrovascular system in a setting of other risk factors. However, to our knowledge, there are no reports on a patient with hemorrhage in the absence of risk factors. So, sorry. Coming to the case one, a 14-year-old COVID-19 positive male patient. Again, I'm focusing on the age of the patient. As a 14-year-old, presenting with the complaints of low-grade fever since 7 days, cough since 4 days, body ache since 5 days, vomiting 5 episodes since 1 day, and drowsiness since 1 day. On day 2 of admission, patient developed quadriplegia and he was having intact awareness. That's what we call Locked-in syndrome. The pulse of the patient is 100 per minute. SpO2 was 98% on room air. BP was 130 by 80. Respiratory rate was 80 per minute. Again, the BP was not raised in this patient. There was no history of hypertension in the patient, no history of antiplatelet use, no history of anticoagulant take, and no history of CKD. MRI was suggestive of acute multiple hemorrhages in the bilateral pons. On coming to the lab parameters, the HB of the patient was 13.5. Platelet count was absolutely normal, that is 1,56,000. Fibrinogen was not elevated more than 500. CRP was normal. So CRP was raised 108. CSF examination of the patient was done. It was absolutely normal for the routine and also for the viral panel. The 2D echo of the patient was absolutely normal. The PT-INR was 12.5 for the patient and our control in our hospital is 12.1. So the ratio for INR is 1.04. D-dimer was 353, ferritin was 1055. The HRCT of the patient was suggestive of multiple ground glass opacities in bilateral lung parenchyma. The neurotrophic virus panel again negative. The ANA of the patient was young. It was also suggestive of a negative result. So this is the MRI finding of the patient suggestive of acute multiple bilateral pontine hemorrhages involving the ventral pons. The case two is a 21-year-old male COVID-19 patient presented with the complaints of cough since 2 days, breathlessness over day, and right-sided weakness since 1 day. The patient having pulse rate of 119 per minute, SpO2 of 91% on room air, SpO2 of 91% room air, respiratory rate was 17 per minute, BP was 160 by 100. Patient had no past history of ischemic heart disease, CVA, hypertension, diabetes, liver parenchymal disease. The patient was not on any anticoagulant or antiplatelet medication. None was given in the hospital. The X-ray was suggestive of bilateral basal infiltrates. CT was suggestive of acute and CT brain was suggestive of acute intraparenchymal hemorrhage in the left pons. The lab parameters was HB was 10.5, platelet was 186,000, fibrinogen was 471, CRP was 228. CSF examination again was normal for the routine CS examination. 2D echo was absolutely normal. PT was 12.9 and INR was 1.14. D dimer was 13.53. Ferritin was 1055, and the ANA profile of the patient was negative. So this is the CT of the patient, which was done in the casualty itself, was suggestive of acute left ventral pontine bleed with a 2 mm midline shift. Coming to the case 3, it was a 19-year-old female, COVID-19 positive, presented with the complaints of breathlessness and cough since 2 days. SpO2 of 94% on room air, BP of 140 by 100 mm of mercury, respiratory rate was 18, pulse was 109 per minute. On day 3, patient became disoriented. CSF of the patient was done to suggestive of normal. On day 4, patient developed acute right-sided weakness. There was no past history of diabetes, hypertension, CVA, ILD, and TB. No history of anticoagulant or antiplatelet use. None was given in the hospital. CT was suggestive of acute intracerebral hemorrhage in the left parieto-occipital lobe. Her lab parameters was HB was 16.5, platelet count was 166,000. Fibrinogen was 269, CRP was 98, CSF examination was absolutely normal. 2D echo was having normal LV function with EF of 55%. PT was 12.5, INR was 1.01, D dimer was 983, ferritin was 685, and ANA of the patient was again negative. So this was a CT scan of the patient showing left acute parieto-occipital bleeding with 12 mm of midline shift. Coming to the case 4, last case 4, it was 27-year-old male patient, COVID-19 positive, admitted with the history of sudden onset loss of consciousness and left-sided hemiplegia, along with the sensory loss on the same side. SpO2 was 90% on the room air, BP was 150 by 100, respiratory rate was 22, pulse was 130 per minute. No past history of diabetes, hypertension, CVA, ISD, or the TB. There was no history of anticoagulant and antiplatelet use, and none was given in the hospital. Coming to the lab parameters, HB was 13.5, platelet was 156,000, fibrinogen 574, CRP was 300, CSA examination was normal, 2D was normal, PT-INR was 12.5 and INR was 1.04. D dimer was 853, ferritin was 476, and ANA profile was negative. Acute, this is the CT scan of the patient showed acute right occipitotemporal bleeding. Coming to the discussion part, the results demonstrate the potential for intracranial hemorrhage in patient with COVID-19 despite no apparent bleeding diastasis or use of any antiplatelet or anticoagulant drugs. The strength of this result lies in its novelty, and in our patient, lack of previously associated risk factors such as provocative factors for intracranial hemorrhage, such as hypertensive emergency, anticoagulation medication, or antiplatelet medication use. The mechanism proposed for the intracranial bleeding in the COVID-19 patients are systemic infection of SARS-CoV-2 can lead to a cytokine production, that is mainly ILC is called cytokine storm, as a part of innate immunity. The cytokine inflammatory response activates endothelial cells, which results in endothelial injury. This is the first part. Second part going to SARS-CoV-2 virus has been demonstrated to bind angiotensin converting enzyme 2 on the endothelial surfaces. The ACE2 receptor are expressed on lung, intestine, and brain. This binding inhibits the local protective function of ACE2 and likely compromise the endothelial integrity by depletion of angiotensin converting enzyme 2. So this will be the second mechanism. So the patient, mainly COVID patient, mainly present with a severe cough. Now there was a previous research where severe cough was reported to cause cerebral hemorrhage in patient with the whooping cough as early in 1885. The other case reporting intracerebral hemorrhage in patient of COVID-19 are: one was 79-year-old man who did not receive anticoagulant and had normal platelet levels. Yes, sir. Okay.
Time is over. Conclude fast.
Yes, okay. Coming to the conclusion, physician, including neurologists, should have aware of the fact that COVID-19 disease can cause acute hemorrhages. Increased risk of intracerebral hemorrhage adds on the complexity of management of patient with COVID-19. Patient with the violent sneezing or coughing should be closely observed as they are additionally predisposed to the intracerebral hemorrhage. These are our paper details such cases in patient not on any coagulation antiplatelet therapy. However, the risks are likely to be higher in patient also on the anticoagulant antiplatelet therapy. We believe this additional risk to do the virus ability to bind angiotensin converting enzyme to on endothelial surface. Further research is warranted to understand the COVID-19 associated coagulopathy to prevent cerebrovascular accident. These are my references. Thank you, sir.
Okay, thank you. Any questions? Okay, if there are no questions, we go to next candidate, that is Kushal Durge. Kushal, are you ready?
Yes, sir. Yes, sir.
Akash, you stop.
Yes, sir.
Akash, you stop.
Yes, sir.
So that Kushal can join.
Yes, sir.
Okay, Kushal.
Yes, sir. I am audible.
Yes,
Hello?
please carry on.
Audible. Hi, I am
Carry
Dr.
on.
Kushal Durge, Medicine Department, SMPT of Institute Medical College and Dhamangaon, Nashik. Sir. Today I will presenting the brain abscess in adult with uncorrected tetralogy of Fallot. Introduction. One of the most common cyanotic congenital heart disease in children is tetralogy of Fallot. It occurs in 3 out of every 10,000 live births and accounts for up to 1/10 of all congenital cardiac lesion. The patient with congenital heart disease are prone to develop cerebral abscess, incidence being 4 to 6%. Tetralogy of Fallot is the most common cyanotic congenital heart disease, accounting for 13 to 70% of the all brain abscess cases. Most of them are located in the supratentorial compartment and are most common in 4 to 7 years of the age. The incidence of the cerebral abscess in patients with tetralogy of Fallot is due to the fact that microorganisms in blood, instead of passing through the pulmonary circulation and undergoing phagocytosis, passes from the right to left shunt, though the shunt and gain access to the cerebral circulation. The prognosis of a congenital abscess is worse than that of the brain abscesses, and mortality rate have ranged from 27.5 to 71%. Management options include the antibiotic for 6 to 8 weeks, aspiration under local anesthesia, and excision of abscess under the general anesthesia. Aspiration of abscess under local anesthesia is the most common because of greater risk associated with the general anesthesia. My case report is a 27-year-old male presented to our medicine department and complained with headache, high-grade fever, and left hemiparesis, followed by the generalized tonic-clonic seizure. He was diagnosed to have tetralogy of Fallot at 10 years of age and had not underwent the corrective surgery. On examination, had pulse rate is 126 beat per minute and BP is 100 per 70 mmHg and temperature is 102 Fahrenheit. And patient is a central and peripheral cyanosis and grade 3 clubbings. On examination, patient was conscious when GCS is 13/15 and power was decreasing, that is 4/5 in left upper limb and lower limbs with brisk reflexes and upgoing left plantars. JVP is elevated and there is a left parasternal heavy was present. Pan-systolic murmur on auscultation and ejection systolic murmur they are present. And his lab doing, there is hemoglobin is elevated and that is 18 gram per deciliter and hematocrit is 57%, that is suggest of the secondary polycythemia. And TLC was 15,000 and platelet is 90 decreasing, that is 98,000 and AST was 66 and LDH was 400. And there is a negative viral marker is negative and there is echo done, there is suggest of the tetralogy of Fallot and there is ejection fraction is 66%. And also there is a ELP done, there is a suggestion of the bacterial infection. And a blood culture is also sent and which all reports is there is no any growth. And MRI also done. And there is suggestion of the ring enhancing lesion, that is the size is 3.5 into 2 into 2.8 into 2 centimeters, right parietal lobes with significant surrounding edema. Suggestion of the brain abscess given in figures. And this is suggested of the brain abscess in the right parietal regions and sit in T2 regions. And the CT also done. There is a suggestion of the there is hypotensive regions in the right parietal region. And after that, neurosurgical consultation was obtained. There is a said that there is a conservative management because of the high cardiopulmonary risk associated with the general anesthesia and low platelet count. He was given in combination of the IV antibiotic, including injection meropenem 1 gram 12 hours and also given the metronidazole 500 mg IV TDS for 6 weeks. Seizure after admission was controlled with the injection of diazepam, that is, and followed by the carbamazepine 200 mg 8 hourly. Fever settled in the following weeks and the power deficit improved within the 3rd week. He was discharged after 6 weeks, and there is no residual neurological deficit, and there is advice for surgical correction of tetralogy fillet and regular follow-up every 3 months. And discussion, tetralogy fillet is one of the most common congenital heart disease in children. The report of describing adult male with the tetralogy fillet who presented in emergency with neurologic manifestation of cerebral abscess and was identified to have brain abscess. The brain abscess is no serious complication. It's uncorrected cyanotic congenital heart disease, although it may be occurs in uncorrected cyanotic congenital heart as well. It is frequently reported in developing countries due to the delay in diagnosis and correction because of paucity of pediatric cardiologists and there is cardiac surgeon. Without corrective surgery, survival rate of adult with tetralogy fillet ranging from 10 to 12 years, and only up to 10% of the population live to their 30 age, and 3% up to the 40 age or beyond. Hypothermia and hyperviscosity are the two main factors that predispose the patient with tetralogy of Fallot to brain abscess. Hyperviscosity reduces the flow of blood to microvascular and causes the infarction, which get infected and develop focal cerebritis and then abscess. Thirdly, microorganism is the blood evade to the pulmonary circulation and hence phagocytis due to the sending of the blood from the right to left heart and gain entry to cerebral circulation. The fact is further supported that the most of the report of the brain abscess in tetralogy fillet describe the anaerobic bacterial growth on cultures. Management of the brain abscess among the cyanotic heart disease, there is a special problem. There is a patient have the coagulation defect in addition to the cardiopulmonary risk. Both the factor increase the risk of anesthesia and surgery. This consider controversy regarding the choice of the medical versus surgical therapy in patient with cardiac brain abscess. Surgical options of the brain abscess include the drainage through the osteoplastic craniotomy and removal of the abscess or aspiration of the drainage abscess stereostatic guidance. The procedure can be performed under the general of the scarf under the local anesthesia with good result, but it requires expensive apparatus and expertise. The reported patient with the thrombocytopenia and to so decision to have managed and conservatively with the combination of the triple antibiotic which unproved is accessible. Conservative management with the IV antibiotics may be recommended in initial management option in patient with tetralogy fillet present with the brain abscess in a high-risk surgical patient. My conclusion was, in patient of tetralogy fillet presenting with fever and acute neurological feature including headache, limb weakness, or seizure, a high risk of suspicion of the brain abscess must be kept as an early detection, and prompt antibiotic treatment reduces the morbidity and mortality with complete resolution of the lesion, especially in high surgical risk patient. Patients should also be encouraged to undergo corrective surgery as early as possible for a near normal life and prevention of further potential fatal complication. This is my references, sir. Thank you, sir.
Okay, thank you, Kushal, for finishing in time. Any questions from judges? Okay, if there are no questions, we go to next candidate, that is Harsha Kadam. Harsha, are you ready? Kushal, will you please stop sharing your screen?
Yes, sir.
Is Harsha Kadam around? Harsha Kadam? Okay, before we go to the last presentation by Nikhil Gite, I would like to introduce our judges. Dr. Lashmikant Yange, he is a very senior pulmonologist. He is practiced in Pune. And Dr. Varsha Shinde, she is HOD Emergency Medicine at DY Patil, and she is an anesthetist. And I am myself, Dr. Kulkarni, I am HOD Surgery, Vajpayee Medical College. So we'll go to the last presentation by Nikhil Gite. Nikhil Gite? Are you available, Nikhil? I think looks like we're done. Varsha and Lakshmikant. The last two participants, they are not responding.
Okay.
So we're done.
We have some time. I think we skipped questions to many participants. So they may feel that if there is a separate. Yes.
Huh?
Okay. Dr. Kushal, can you mute yourself? Okay, fine. So we missed some questions to many participants. Any of them is around now, to whom we have not yet asked any questions. They might feel that without asking question, how can you score me on question and answer part of the assessment?
Okay. Sorry. Yes.
Okay, so all of them who are present right now, I think we have asked questions. I think then we can go to conclusion, sir.
Yeah. So should we call it a day, Varsha?
Yes, from my side, yes.
Rashmikant sir, okay?
Yes, sir.
We
Yes,
stop?
yes, sir. Please.
Yeah. Thank you very much. Thank you, DigiShield, and thank you all participants for taking part. I think we finished in time. Thank you very much.